one important topic, that is epithelial tissue by epithelium. Now, this is mainly related to the histological aspect of anatomy. Histology, you know what is histology? What the study of tissue under microscope. Microscope the polarity, but under microscope. In normal eye, you cannot see. You have to see under microscope. Okay. So this will be helpful both for theoretical questions and also for practical topics. Epithelial tissue or epithelium. Now, first leg. First definition. These are a type of cells. There are tissues are made of cells. These are type of cells that lines the body surfaces. That lines the body surfaces. What is the meaning of body surfaces? That both external and internal skin only, this is the body surface. Internal কি আছে ওরা যে একটা নিউক্লিয়াস আছে ইসোফেগাস ক্যারি সবার একটা লাইনিং সারফেস আছে এই লাইনিং সারফেস and superficial surface these are lined by some cells but a tissue that is known as epithelial tissue. Okay, তো আমি একটা পুলিশের সাথে আমি ডিটেইলস যাচ্ছি এটা বলতে এসেছে ঠিক আছে that এবারে কি হচ্ছে both the external and internal. It is internal का बोलेगा और internal is lined by everything. Okay. Now, what are the characteristics of epithelial cells? लिखे देंगे तो छोटे characteristics. Easy. Property. Characteristics of epithelial. Number one. They are closely packed. They are closely packed. Now, look at epithelial cell. This is the epithelial cell. Epithelial cell is the epithelial cell. There is no gap between the cells. Not like this. Okay? There is no gap between the cells. Closely packed. First. Second, that is very important. The cells rests on a basement membrane. The cells rest on a basement membrane. The basement membrane, what is the basement membrane? It is fibrous structure on which the epithelial tissues rest. It is external part of the skin. This is the internal. There is no part of the This is the outer part. This is the inner part. The inner part is the and the side is the inner side. This is why deep sleeper side. What is it? Deeper side and the basement membrane like that.
Sir, আমাদের epithelial cells কমা শক্তি হয়ে গেছে। কালকে স্যার স্লাইড না না থিওরি
ঠিক আছে আমরা প্র্যাকটিস काम हो गया प्लीज लाइक बेस में ओके thirdly the epithelial cells do not have capillaries of their own. The epithelial cells the nasal capillary do not have capillaries of their own. What does the function of capillary? To supply nutrition, to carry waste products, oxygen. In epithelial cells there are no capillaries of its own. So how does it get its nutrition? Basement means diffusion. And it gets its nutrition by diffusion from nearby capillaries. It gets its nutrition by diffusion from nearby capillaries. Third, effort destroyed by wear and tear. माने there are constant destruction. The destruction must be replenished. There is also regular regeneration. The destroyed by wear and tear, therefore also regular regeneration. My new cells are produced. Clear? Any doubt up to now? Now come to functions. Functions के बहुत First one protection. ये skin का मतलब कुछ प्रोटेक्ट करते बाहर ओके इंटरनल स्ट्रक्चर पे प्रोटेक्ट करते तो first one protection. Second absorption. What is it in the GI gastric tract? Absorption. Fourth function secretion. Secret कुछ जेट mucus पर ये secret कुछ ठीक है जी ये secretion है important सेल नाम goblets GOBLET goblets why it is found in stomach GI tract GIT and respiratory ये देखिए लास्ट क्वेश्चन लुब्रिकेशन what does the word lubrication means आप तो पाए मुझे तो नहीं ना सब ठीक है मुझे लेकिन नॉर्मल का what the word lubrication in cars requires that grease that for lubrication. The to reduce friction. reduce friction between two surfaces. The surface আছে এই দুটো সারফেসের মধ্যে ফ্রিকশন রিডিউস করার জন্য এখানে কি হচ্ছে লুব্রিকেটর একটা অয়েল তৈরি দিয়ে দিচ্ছে, তাই তো? তাহলে সেটাকে বলা হচ্ছে লুব্রিকেট, যাতে ফ্রিকশনটা we can prevent much of the friction, prevent friction. Okay. So while it is present in the friction को देने के बाद serous cavities, serous cavities. This is important for serous cavities. ना serous cavity है ना बोल serous cavity এগুলো হচ্ছে পেরিটোনিয়াম পেরিকার্ডিয়াম পুরো এই ক্যাভিটি গুলোকে সেগুলো ডিটেইলসে পড়া হবে এগুলোকে serous cavity ধরুন দুটো প্লুরাল লেয়ার তার মধ্যে লুব্রিকেশন দুটোর মধ্যে সবসময় কি হচ্ছে উই আর টেকিং এক্সপ্রেশন দুটোর মধ্যে একটা মুভমেন্ট হচ্ছে তাদের ফ্রিকশন প্রিভেন্ট দ্যাট ফ্রিকশন দিস লেয়ারস আর এখানে এপিথেলিয়াল লেয়ার that lubricates and prevents destruction of this damage to this layers. The chapter function কি হলো? First notice, second absorb, third কি বল? Secretion, of course. Now coming to few terms, बहुत important है इसको एरिया का भालो बुझो कारण this will be required to whole थोड़ा फास्ट के लागবে सेकंड ईयर है तो पैथोलॉजी देंगे this will be required तो टाइम में हिस्टो पैथोलॉजी हां ये हमारे फर्स्ट ईयर और सेकंड ईयर में डिफरेंस में फर्स्ट ईयर we only read about the normal things anatomy of physiology that is the normal things in second year we will go to the disease part of the abnormal. The first you know the abnormal, then you can say what is abnormal. If I don't know what is normal, then how can I say what is abnormal? Therefore, the first year we mostly read about normal. Therefore, in this year this is histology. In the second year, is pathology. There will be histopathology. So, abnormal tissues, abnormality of tissues, or disease tissues. Okay. So, this year we will concentrate mainly with normal. And you will check features for here तो you will calculate इतना important first term the cell एपिथेलियल আমরা সেল হিসেবে কিভাবে ভাববো এটা কি ভালো বুঝবি you must understand this thing okay this will সব সময় সেল তাহলে সেল of cells not tissue cell of cells now এটা বলবো আগে একটা বলবো তো হিস্টোরিতে you have to practical copy as you have to I mean, theory to draw. Second one is কি জানিস নিউক্লিয়াস কে কি রকম হয় blue can why are cytoplasm pink why কি জানেন না ও নরমাল হেমোটোক্সিন HNP দা সেগুলো যদি হিস্টোরিক্যাল ডিটেইলসে বলা হবে আমি অত ডিটেইলসে যাচ্ছি in therefore you have to draw the nucleus in blue and the cytoplasm in pink. So for theoretical purpose, practical pure after theoretical purpose, full cytoplasm drawn করতে হয় না just the cell membrane এটাকে আমি pink কে আমরা এখানে pink নেই বলে এটা রাখতে হচ্ছে আমাদের আর nucleus draw করে এই যে nucleus blue and cytoplasm pink. Can also because we see after staining is the hemotoxilic and leucine. Okay. So যখন আমরা histology জানবো বা theory জানবো we will try to draw like this. Normally it is colorless. কিছু দেখতে হবে colorless ওটা টাইপ to make that contrast. That is where you can replace কোন জায়গায়. Okay. Which is aspect called the base membrane. Okay. The cell will be on the base membrane. What we call the characteristic. First one is the squamous cells. What are they? Yes. Squamous means chapter, flattened. The term squamous means flattened. Okay. Now these are flattened. That means the height will be small and the length will be relatively large. Flattened means that chapter means that. Then this is represents the sorry. Big this is the structure of nucleus. Nucleus is almost in the middle. The height is much smaller relative to the length. That is flattened cells. That is squamous. Squamous comes flattened.
The height of weight what is it?
Second, height and length almost same. The cuboid. Mana? Spelling? C-U-B-O-I-D-A-L. Here, the length and height is almost same. Exact same. Almost same. Again, center is what are you? And third one is the columnar. Column means key. Columns what are rows and columns? Now your height is much more than length. Great than the length. Now, one thing you note here, the nucleus location. We are at the basal base. Now, we are at the basal base. Towards the basal base. That is the column. What is it? Now these are the cell, according to cell. Now, second year, according to number of years. According to number of years, what is the number of years? After we grow use just the after first simple. The single layer. What are the simple? Single. What is the meaning? Single layer. Second function, compound. Multiple layers. one and a half কিন্তু কোনো স্পেস নেই কম্প্যাক্ট থাকে ওকে the simple compound simple মানে সিঙ্গেল লেয়ার compound মানে এবার পরের জিনিসটা আমরা পড়ব that is keratinized and non keratinized let বানানটাকে একবার বলতে পারবি this is keratinized. So what is the meaning of keratinized? Keratin person. This is found in only compound বা brachial stratified squamous cells. This is found in compound in bracket stratified. Stratified মানে হচ্ছে is here stratified এটা কোন বলছি stratified মানে মাল্টিপল লেয়ার আছে ঠিক আছে stratified মানে কম্পাউন্ডের একটা অংশ মাল্টিপল লেয়ার হচ্ছে stratified squamous keratinized or non keratinized এটা হচ্ছে only stratified squamous কম্পাউন্ডের keratinized বা non keratinized দুটো করব তাহলে only stratified squamous okay তো keratin what is keratin what's it the stratified squamous multiple flattened cells are here right multiple flattened cells so देखो सर ये प्रकार से चलता है पूरा फास्ट कर दिया आपको बोले लेकिन देखो अच्छे सोए so this is squamous as stratified multiple layer stratified squamous layers are multiple layers এবার কি হচ্ছে outer যে layer the most superficial layer in dry places মানে যেমন স্কিন এইগুলো কি হচ্ছে dry places the superficial layer die forming a chemical like skin but non living chemical living cells are living the non living একটা particle form হয় that is known as কি keratin or in case of wet places there are mucosa in wet places the superficial layer do not die but dry out শুকিয়ে যাচ্ছে না layer therefore এগুলো non keratin কিন্তু keratin ব্যবহার করতে কি করে করতে একটা ব্লু রঙের বা পিঙ্ক রঙের দেওয়া উপরে এরকম একটা क्या मैं देखिए नॉन लिविंग keratin is a non living thing living না সেলের উপর একটা নন লিভিং লেয়ার কি বোঝা গেল তাহলে ড্রাই প্লেস স্কিন ওই হেয়ার ফেয়ার বললি তারপর ওগুলো তো কিছু keratinized stratified squamous but in case of wet inside of the body esophagus এখানে কিন্তু আমরা non keratinized clear keratinized and non keratinized is however this is only found in stratified squamous মানে এখানে প্রথম বলতে stratified কারণে মাল্টিপল লেয়ার সুপারফিশিয়াল লেয়ার একটা লেয়ার হবে আর দ্বিতীয় stratified squamous এই হবে অন্য কোথাও কিন্তু আমরা keratinized বা non keratinized শব্দটা ইউজ করব না ওকে keratinized now coming to cilia cilia small projections are cilia are filamentous threads lying on the surface of the cells তাহলে এগুলো কিন্তু ভেরি স্মল অনেক বলছো ভেরি স্মল এবং এগুলো মাল্টিপল থাকে একটা সিঙ্গেল সেলে অনেকগুলো থাকে দুটো হচ্ছে সেল ইজ সো স্মল তার মধ্যে অনেকগুলো মাল্টিপল আছে ওকে তো cilia is a filamentous thread, very filamentous thread projecting from the surface of the epithelial cells. Okay, surface of epithelial cells থেকে projected. So কেমন দেখতে? If this is the cell, right? Now, cilia is of two types. You want it? Specifically, দুটো cilia হয়, একটা হচ্ছে moon type, সোজা, অবশ্যই। These are columnar cells. তাহলে এগুলো তো columnary epithelium. Squamous তো শুরু শুরু পাবে না, tubular পাবে না, আপনি তো columnary পাবে। Okay, these are columnar cells, but all the cells do not reach the surface. The surface পর্যন্ত পৌঁছাচ্ছে। And all the cells do not reach the surface. Brachial layer generally they are ciliate. তাহলে এর মধ্যে generally সবসময় নাও থাকতে পারে, বেশিরভাগ ক্ষেত্রে দেখা যায় এর সঙ্গে cilia আছে। এবার লিখে এক্সাম্পল রেসপিরেটরি ট্র্যাক্ট। আমি কেন এখানে রেসপিরেটরি সিলিয়েটেড লেখার না, একটু স্পেশালাইজেশন। এটা যদি কেউ ধরুন ভুল করে রেসপিরেটরি যদি বলে যে কলামনার সিলিয়েটেড epithelium, তাহলে কিন্তু ভুল না, কারণ কলামনার সেলস ইম্পর্টেন্ট। আরো স্পেসিফিক হতে গেলে কিন্তু সিউডোস্ট্যাটিক হবে। যদি এটা যদি কেউ বলে যে কলামনার epithelium এর উপর ভিতর দিকে লাইন অফ দা কি বলে রেসপিরেটরি আপার রেসপিরেটরি কিন্তু বলি সিলিয়েটেড কলামনার, ইট ইজ নট রং। কিন্তু আমি যদি পড়াচ্ছি আরো স্পেসিফিক জিনিসটা বলে দেওয়া হচ্ছে, সিউডোস্ট্যাটিফাইড কলামনার সিলিয়েটেড সিউডোস্ট্যাটিফাইড কলামনার। তাহলে আমাদের সিম্পল হয়ে গেল। এবার আই নিয়ে তো কি বলতো নামটা স্ট্যাটিফাইড। তাহলে হয়ে গেছে। কোন স্ট্যাটিফাইড কম্পাউন্ড কম্পাউন্ডে এক নম্বর দিলে স্ট্যাটিফাইড, কম্পাউন্ডে এক নম্বর দিলে স্ট্যাটিফাইড। ঠিক আছে, এবারে স্ট্যাটিফাইড কি আছে না, প্রথমে স্ট্যাটিফাইড স্কোয়ামাস। It was certified under certified squamous. Certified squamous. এবার কি ইম্পর্টেন্ট certified squamous খুব ইম্পর্টেন্ট হলো এর ফাংশন ঠিক আছে, প্রোটেক্ট সেল কমা রেজিস্ট ফ্রিকশন, ফ্রিকশনটাকে রেজিস্ট করে প্রোটেকশন কিভাবে রেজিস্ট ফ্রিকশন। তাহলে আমরা ভালোভাবে দেখো রেজিস্ট ফ্রিকশন মানে কি, মাল্টিপল লেয়ার সাথে ওপর লেয়ারে যদি ভর্তি হয়, দ্বিতীয় লেয়ারে কিন্তু 15টা লেয়ার আছে, কিন্তু প্রথম 4টে লেয়ারে ভর্তি হয়, তাহলে কিন্তু বাকি আর লেয়ার থেকে যাচ্ছে। ফ্রিকশনের জন্য উপরে ধরে 4 লেয়ারস আর ক্যাম্পড সুপারফিশিয়াল 4 লেয়ারস স্টিল 11 লেয়ারস লাগে, সেজন্য মাল্টিপল লেয়ার। এটা কোথায় পাওয়া যাবে, কোথায় ফ্রিকশন হয় তাহলে ভেবে দেখ একটা স্কিন কম সময় যখন চেঞ্জ করছে ফিক্সের কিছু কন্টিনিউয়াস আর কোথাও ফিক্সের কিছু জিআই আপনার যে কি মুখে ধরে তুই হার্ট বলছিস ওখানে মুখের মধ্যে যে মিউকোসা দ্যাট উইল ইনজিওর ফ্রিকশন হচ্ছে দেন ইউ আর সোয়ালো যদি ফ্যারিংস এন্ড সুফিক্স আবার কথা লাস্ট পড়াতে আমি থাকি ওখানে কারণ শেষ হচ্ছে সেখানে পাবো আর দেখো কাজা আরেকটা জায়গায় পড়ে কেমন লাগে সেটা হচ্ছে পয়েন্ট চোখের বাইরে দিকে ওটা ভিতরে ফিক্সেশন দিয়ে আউটার লেয়ার ফিক্সেশন হবে তাহলে এইটাতে মেইন লিখে রাখবে এটাও দুটো ভাগ করে যায় ভাগটা করে দিই একটা কেরাটিনাইজ স্ট্রেটিফাইড স্কোমাস আর একটা হচ্ছে নন কেরাটিনাইজ আগে এই ভাগটা করে নিই ঠিক আছে কেরাটিনাইজ স্কোমাস एग्जांपल এপিডার্মিস অফ স্কিন অলওয়েজ কোনো কিছু স্কিন অফ ফুল আছে শুধু স্কিন বলে থামবি না এপিডার্মিস অফ স্কিন আউটার লেয়ার যেটা আছে এপিডার্মিস মানে হচ্ছে EPIDERMIS এপিডার্মিস অফ স্কিন ডার্মিসটা কিন্তু নয় ঠিক আছে তো এটা হচ্ছে কেরাটিনাইজ স্কোমাস एग्जांपल নন কেরাটিনাইজ এবার দেখব কি ভাবলে কি ওরাল ক্যাভিটি বা ওরাল ক্যাভিটি মিউকোসা ওরাল ক্যাভিটি ये लोअर फेरिंक्स इसोफेगस স্টমাকে কেন না স্টমাকে যদি করে জিনিসটা কি ব্লাস্ট হয়ে যাচ্ছে তখন কিন্তু ফ্রিকশন যা হবে বেশি হবে আর স্টমাকে তো ফাস্ট মুভমেন্ট হবে স্টমাকে কি হবে ইট রেস্ট স্টমাক কতক্ষণ থাকে প্রায় 2-3 ঘন্টা থাকে স্টমাক মিনিমাম সেই জন্য কি ওরাল ক্যাভিটি লোয়ার ফেরিংস এন্ড ইসোফেগস তার সঙ্গে কন্টিনিউ হবে ये understood the cause by পুরো মনে থাকে তো কেন এটা থাকতে পারছে তাহলে এটা হয়ে গেল এবার লিখে দেন তাহলে স্কোমাস হয়ে গেল বি হচ্ছে স্ট্র্যাটিফাইড কিউবিটি যেটা রেয়ার পাওয়া যায় एग्जांपल दे ducts of some exocrine glands ducts exocrine glands ducts থাকে জানিস তার ducts লাইন আছে stratified ducts of exocrine glands some exocrine glands a stratified columnar bigger one example squamous টা বুঝতে পারছিস সবাই columnar টা যখন কিউবিটা দেখতে হবে কিউবিটা হচ্ছে ducts of example of some exocrine glands ducts exocrine glands এর নাম যেখানে সিকনেসের হয় কিছু আর সেকেন্ড হচ্ছে ইয়ে মানে কি বলবো স্ট্রাটিফাইড কিউবিটা সেটা কোথায় পাওয়া যায় পঞ্জেন্ট stratified columnar পঞ্জেন্ট আর কিউবিটা হচ্ছে ducts of exocrine glands exocrine glands জানিস তো কত বলে আগে বলছি এই stratified cubital and stratified columnar is relatively rare ঠিক আছে এবার লাস্ট জিনিস যে 2 নম্বর পয়েন্ট ট্রানজিশন জাস্ট দেখিয়ে আজকে ক্লাস শেষ change or you have transited from school life to college life then you have change তাহলে যে বিষয়টা নিয়ে সেটাকে তুমি চেঞ্জ করতে পারো দ্যাট ইজ নন অ্যাজ ট্রান্সফার বুঝতে কি রকম সরি এই ডিসিপ্লিন করলে এবারে যে ডিপ ইয়ার দেখে কি বললাম কোন থেকে বললাম তাহলে মাত্র কি আসছে the deeper layers are small flattened cells the deep layers is small flattened Packet is small size. ছোট size. তার সবচেয়ে ডিপ গিয়ার তারপরে গিয়ার এটা একটা থেকে দুটো থাকতে পারে তিনটে থাকতে পারে আমি একটা আমি বোঝা বলতে সেকেন্ড গিয়ারটা হচ্ছে পিয়ার cells with the pointing end towards the base. It is pointing end से पियर है दोस्तों तो ये लास्ट में क्या बोले वो है ताकि pointing end that is facing the base to base. ये pointing end इसकी तरह से तो এটা হচ্ছে intermediate দেখে দিচ্ছি intermediate gap here cells here cells with ends pointing ends towards basement membrane. और बुझे ना और पास पास में मत है और लास्ट में मुझे superficial polymeter large polymeter cells large polymeter cells तो तीन लोग cells होते हैं पियर cells pointing ends what is the वैसे और ऊपर superficial layer है कि होते large polymeter cells now এটা মেন কাজ কি কনসেপ্ট আছে এটা একটা হচ্ছে can resist stretching of bladder resist stretching bladder যে bladder থাকে পেটে urine bladder stretching of urine bladder আর নাম্বার 2 impermeable to fluid জলের মধ্যে বের হবে ঠিক আছে impermeable to fluid জল মধ্যে বের হবে এবারে एग्जांपल এখানে একটু ইম্পর্টেন্ট एग्जांपलটা কোথায় পাওয়া যায় urinary bladder and urine ওকে urinary bladder and urine সেজন্য এর নাম হচ্ছে urethra যদি urinary tract এর রেসিপিটা পাওয়া যায় The applicant therefore is known as urinary bladder. No, gallbladder. Urinary bladder. Yeah, urinary bladder. They are known as urethra.
I have something yesterday. Now, we will continue in this topic. For external respiration, our amount of air must enter into the alveoli. And for this purpose, there must be some particular path. And chest wall, and there are and they provide pumping mechanism, and they are skeletal muscle. So respiration is almost involuntary. We are not conscious about this, but they utilize the respiratory system muscles for different purposes, like equalization or blowing or many other purposes. And for this reason, The nature has made so that they are controllable. Controllable. Surrounded by the parietal regional and in the regular space. And normally it is negative. Normally it is negative. Normally it is negative. That is below the atmospheric section. Atmospheric. And negativity in the erect position is not same at every level. But to take the base of the lung, but it is in the resting position. It is minus 2.5 millimeter of muscle at the end of normal expiration. Normal expiration. And between the normal respiration of idle respiration, idle volume, there is that. And the level of their interest. This purpose negativity is the negative. Now, microphone should be over. Negativity is increased. Negativity is increased. Normally, the respiratory rate in resting condition is 12 to 15 per minute. If you take it 15 per minute, that is 15 excursion per minute. So 4 seconds you can take for inspiration and expiration. 4 seconds. And in the plates, they drop bigger in this way. In this way. And the time scale second. Now we consider pressure at different levels. Intrapulmonary pressure. Intrapulmonary pressure. That is the pressure present at the depth of the lung or intra-alveolar pressure. Intrapulmonary pressure. So that at the zero level, you take a zero level. Now with inspiration, this is inspiration and this is expiration. I can navigate it every level. This is how it is. I have what discussion. There is no need of rewriting this. Everything is inspiration. So understanding is most important. So at the beginning of inspiration, we inspire, expire, alternate. At the end of normal expiration, inspiration begins. And then initially it is zero, and then it will go into this pressure. What pressure? Intrapulmonary pressure. And so it will gradually reduce. Roughly it is 1 millimeter of mercury or so. Normal. And at the end of inspiration, again it is the zero level. And then what occurs? Then there is increase in this pressure. In this way, it is taking place. Pressure change within the lungs. After normal expiration, airways in communication with the atmosphere. So its pressure is not that the ambient pressure is zero. Now during inspiration, muscles do contract. Diaphragm and intercostal muscles do contract. And they expand the lungs. And when there is expansion, then there is hollow pressure. And this hollow pressure that is in this direction. And then at the peak, it is minus 1 millimeter mercurius, and at the end of inspiration it attains this valve, 0 valve, and expiration begins. And expiration, then normal inspiration is an active process. Muscles must generate force, and for this purpose energy is required. So it is an active process. And nature is always active, and it maintains the process in such a way the minimum energy is utilized. Some force is required, and by the inspiratory muscles that are produced, and then its work is finished, and next the lung collapses. Due to its elasticity, it will collapse automatically, and no cellular energy is required. So it is passive in that sense. So the energy required for the tidal volume is maintaining tidal respiration is minimum. And in that case, when the lungs relaxes, then there is increasing the pressure. And this is almost same value is attained. And gradually it will reduce to original value of 0 millimeter mercury. So it is the graph of tidal inspiration and expiration and pressure. Many appliances and something is coming in course. What about nature remaining course? It is not everywhere. I have the same experience. Now what about maybe? Now it is equal to the solution. It is appears as a short. Then you have to draw in this way and explain in this way. Now intrapleural pressure. It is intrapulmonary pressure and intrapleural pressure. And in that condition, in the same scale, you can think. Inspiration begins, that is minus 2.5 millimeter of mercury. ppm intrapleural pressure or interpleural pressure, the term is same. There is a potential space. There is a potential space between the visceral and parietal pleura, and there is a thin film of fluid separates them. And it is extremely difficult to separate them manually. They can slide over each other. Separate how much it is difficult. But they can slide it over easily. Similarly, in this case, now at the beginning it is minus 2.5 millimeter of mercury. Now then there is the reduction in pressure. That is the more negative in that sense. More negative. This is the type of, and it is minus 6 millimeter of mercury. 6 millimeter of mercury. Minus 6 millimeter of mercury. There is the reduction in this up to this level. And then this gradually rises. It becomes less negative, and the original value is attained in this intrapleural pressure. But it is not symmetric in that sense. It is not symmetric in that sense.
So it is pressure level.
It is intrapleural pressure. Intrapleural pressure. Pleural cavity ভিতরে যে চাপ আছে সেটা নরমালি সব সময় নেগেটিভ। তার কারণ হচ্ছে আমি বাংলা এটা বলছি তোমাদের যদি যাই চোট কম আছে এই ভাষাটা তাহলে তুমি হয়তো উঠেই যাবে। এখন তোমার হচ্ছে যে এক্ষেত্রে নেগেটিভটা কেন হচ্ছে, কারণ লাংসের স্ট্রাকচারের মধ্যে ইলাস্টিক ফাইবার আছে, তাহলে তার একটা সংকোচন হওয়ার স্বাভাবিক প্রবণতা রয়েছে। আর চেস্ট ওয়ালটা সে বাইরের দিকে এক্সপ্যান্ড করতে চাইছে, তাহলে দুটো শক্তি পরস্পর বিরোধী কাজ করছে। They are working one against another. Lung has a tendency to collapse, and normally the chest wall has a tendency to expand. And this is the primary reason that pressure remains negative within this space. It becomes positive during normally when there is forced expiration, it becomes positive. Forced expiration, it becomes positive. When fluid or air comes, the pressure may increase, go up, or they may be equal to the atmosphere, depending upon the state. Initially, we consider the physiological condition. During deep inspiration, it becomes more negative, and during deep expiration, forced expiration, it may cause more than 30 mm of mercury, or even more than very forceful expiration. Even it is more than 100 forceful expiration. Now you see that figure is skewed. SKEWET মানে একটু মানে সরাসরি একদম সিমেট্রিক না, সুসমান নয়। এখানে যেমন বাইরের সিমেট্রিক্যাল যে ফিগারটা দেখিয়েছি, এই যে এটা দিস নট দেয়ার ইজ সাম স্কিউইং বিকজ you have to encounter the resistances, airway resistance and the viscous tissue resistance. For this reason it is skewed. Clear? Now we have to draw this figure. Draw this figure. That is the beginning of inspiration, the end of expiration, and then it loses this negativity. It will attain the original value of minus 2.5 millimeter of mercury. You have to draw this figure, and you may mention it that if there is nothing intervening except the elastic properties, then you should get this figure, but it is not. Inspiration, expiration, they do not follow the same path. Due to brachial resistance, totally that is the airway resistance and viscous resistance is coming, so that it becomes smooth. Now this volume change can be demonstrated this type of figure. This determination. Whenever there is volume change, that during inspiration, it will attain this value. It will attain this value. Volume change. From the beginning, this volume is the functional and residual capacity. Functional is not. Genetic show. It is a volume change. It is a dot is a volume change. Volume change. এখানে যে হচ্ছে এটা ভূমি রয়েছে, আর এখানে এই বক্র রয়েছে। এই বক্রের শীর্ষবিন্দু এই পাঁচটি রয়েছে। End of expiration. End of expiration. বুঝতে পারছেন? 500 mm. 500 mm. Take this. And this level, from this level, this is the functional residual capacity. Functional residual capacity. Functional residual capacity. And from this gas enters, air enters, and at the peak with 500 expiration, and during expiration, this gas is eliminated, and it will again return muscles are primarily responsible? Diaphragm is primarily responsible. Diaphragm. 75% change is due to this. Diaphragm. The muscular sleeves separating thoracic and abdominal cavities. It has three parts: small sternal part and the costal part. From the lower bottom of the chest, it originates. Lower 6 ribs, it originates. Arching over the liver and abdominal structures, and also on the vertebra, crural part, crural part, and they originate. Crural part, crural part of the vertebra. Still you know the anatomy text. Extremely easy things, I mean, extremely easy things. High secondary course, you have to read all. You have to read all and you have some ideas. And syllabus is changing for the benefit of the nation, so that they can understand many things during their school life. So these preliminary classes are less important. In spite of that, we are serving and we are trying to deliver what we know. But much more in the text, in other information, so you will get it. And your intelligence is whatever it may be. Now 75% of this change is due to the descent of the diaphragm. Normally 1.5 centimeter or so. At deep inspiration, it is even more than 7 centimeters. In different values are there. 1.5 centimeters. So it is in the vertical direction. There is the volume change. It is supplied by the phrenic nerve. Cervical 3, 4 and 5. This do that. Cervical 3, 4 and 5. It is a principal muscle. Another important respiratory muscle is external intercostal. So they are going from rib to rib in this direction, forwards and downwards. So when they contract, they elevate the upper ribs together. They elevate the ribs. And when this type action takes place, the sternum is also pushed forward. So there is an increase in the anteroposterior dimension of the chest. And there is at the same time there is some flare. Pocket handle movement also. So there is increase in the, to some extent, gas mass diameter. And in this way, extra volume is created, negativity is produced. With the help of diaphragm and the external intercostal, and they what good. If there is section of the spinal cord above the level of the C3, then respiration stops. Artificial respiration is required to survive. But if it is below the level of the 5, when the phrenic nerve, when it is not affected, then it can have this function. Diaphragm is active. And in experimental animals, if this, both the phrenic nerves are cut, then there is laborious, but then it maintains life in that condition. Yeah. So either external intercostal or some other muscles. Accessory muscles are also there. Whenever there is requirement during exercise or whenever there is requirement, then there is involvement of the other muscles, the accessory muscles. accessory muscles of inspiration. Inspiration. What are they? Scalene muscle, sternocleidomastoid. Scalene muscles and sternocleidomastoid. Scalene is muscle contains 3 muscles and they insert into the ribs. So when they contract, they activate this thorax, elevate this thorax, and sternocleidomastoid muscle. This muscle, by means of we are doing this type of movement. Sternocleidomastoid. ठीक है तो scalene. And sternocleidomastoid. Scalenus anterior, scalenus posterior, scalenus medius. These are the issues. You will find in anatomy text during dissection. You will show that these are the muscles. That really important function together is the elevation of the thorax and helping the position of inspiration. Sternocleidomastoid has this type of effect. And in the addition to during forced inspiration, these muscles become much bigger. Not only that, any muscle that elevates the pectoral girdle, they do have their. These are the muscles. And this diaphragm has some important function in other cases. And the nerve that supplies the pleural portion is different, to some extent functionally different in some conditions than that of the costal portion. Costal portion মানে রিবের সঙ্গে যেগুলো যুক্ত আছে কোনো কোনো ক্ষেত্রে তারা একসঙ্গে কাজ করে এবং ক্ষেত্র বিশেষে তারা ভিন্ন ভিন্ন ভাবে কাজ করতে পারে as for example in ejaculation and vomiting there is increase in the intra-abdominal pressure and in this process the diaphragm do go lower and that helps to increase the intra-abdominal pressure along with abdominal muscles. But the pleural part they relaxes. This pleural part normally they have pinch cup-like action over the esophagus, and at that time it relaxes. Though it is a part of the same muscle, so that there is the material in the upper part of the gut, stomach as intestine can be eliminated. Otherwise, it will prevent the entry of substances from stomach into the esophagus. But in meat, they do have their function absolutely. Now, expiration is normally a passive process. But whenever there is requirement during exercise, whenever there is increase in ventilation, and in that condition, accessory muscles to come into action. And what are the muscles of expiration? Internal and intercostal. Internal intercostal is a inspiratory muscle. Internal is intercostal. And the direction of the fibers is opposite to that of the external intercostal. External intercostal in this way, along the direction of the fingers, but it is in this direction. Downwards and posterior. So the lower lips, when they have contract, they bring down the thorax below, and reduce this space. Opposite to that of the direction of fibers are different from mid to knee, downwards and posteriorly. So when they contract from below and they inspiration is facilitated by elevation of the thorax and depression of the thorax. And at the same time, what muscles are? Abdominal muscles. Abdominal muscles. They do contact due to forced expiration. Expiration. Forced expiration. Forced expiration. And whatever they do, that is they increase the pressure. Increase the pressure. So that there is a diaphragm, the abdominal contents will be pressure and diaphragm will be elevated. At the same time, they pull down the thoracic cavity, chest below. It's a permanent movement. It will work. Expiration that is related to inspiration movement. External intracranial muscle push up down. They will show you the dawats. They are movement by palm movement. আর যখন এরকম ছড়িয়ে ক্লিয়ারিং হচ্ছে এক্সটার্নাল ইন্টারকস্টালে তখন সেটা বাকেট হ্যান্ডেল ক্লিয়ারিং হচ্ছে দে আর অলরেডি সাইমালটেনিয়াস আমি যখন বাদ দিচ্ছি তখন দুটো মুভমেন্টই হচ্ছে এটা তো ওই রিজার্ভেশন ক্ষেত্রে now it is internal intercostal and abdominal muscles and other muscles that who are this pectoral artery. Suppose during inspiration, deep inspiration, there will be activity of some muscles related to the spine. Or during expiratory muscles, there are some muscles they do have that action. Important muscles, latissimus dorsum. During cupping, there is the hold of the axilla, then it will contract during the course of cupping. It is also placed for the muscles. Latissimus dorsum. But commonly these muscles are the internal muscles and this is the abdominal muscles. These are the expiratory muscles. Expiratory muscles. Normal inspiration does not require this function. During the end of inspiration, there is some braking action. That is expiratory muscles to some extent has control that the expiration is not explosive. It occurs slowly. They have some contraction at the very beginning of inspiratory muscles. So that the expiration is not explosive, it continues for some time. Slowly, relatively slowly. Normal expiration is a passive process. And work of these muscles is demonstrated in different texts by means of different diagrams. One diagram is important I am drawing. Intercrural pressure. See, the curve is not in this one. This is the beginning of inspiration. Inspiratory curve in this one. Pressure may be intercrural pressure or intestinal pressure. The interpulmonary, there is the pulmonary pressure, intestinal pressure.
Sir, একটু ওই অ্যাক্সেন্ট নিয়ে বড় করে লিখুন একটা।
দেখা যাচ্ছে না বলে দিচ্ছি তো তোমাদের everything in your text many texts are available everywhere now at the beginning it is suppose I can remember that I am taking this value interval beginning minus 2.5 beginning in minus 2.5 millimeter of mercury and it will be more beginning at the end of normal inspiration it becomes minus 6 millimeter of mercury 6 millimeter. So that it is the inspiratory curve and it is the expiratory curve. So the and if you take this so the for this purpose you consider that this area AXBC this area this triangle it represents the elastic one elastic one diameter that is the pressure multiplied with the volume is equal to that of the this unit is that of the what pressure suppose in the physics test times per centimeter square centimeters multiplied by the volume centimeter times centimeter and that becomes R and it is the unit of the what R. Short division is extremely easy subject. Now you see that so this areas represent this work done and in this case you consider a homogeneous structure homogeneous elastic properties during that short interval of tidal movement. So that this triangle AXBCA that is the elastic one and this part that is this part. Just due to additional to this part, so we have to work out their force also, and it is due to some is due to frictional resistance and some due to viscosity of resistance of the tissues. This airways within they contain air and the movement whenever there is movement there is some resistance airway resistance at the same time whatever may be the variability of the tissues some force is required for its change in the volume. There is a viscous part they all come together so the total force required for normal inspiration is AYBCA and this part that is the AYBXA and it may be divided into two components major component due to airway resistance and some component due to viscous resistance. Now this expiratory pathway is this expiration AXBJA this one during normal expiration the what during normal expiration and you see in the figure it is following it is within this curve AXBCA and it is passive in that sense there is no extra forces required or this type portion there must be force generation by the muscles during inspiration along with this elastic part so it is an active process but whenever there is end of inspiration the muscles do relax and then the lung collapses and whenever it collapses then what occurs then this one is done and it is within this elastic process within the elastic force so no additional force is required ছেড়ে দেবো গ্র্যাভিটি নেমে যাচ্ছে তার জন্য ফোর্স and for this reason least amount of energy is required. So it is falling within this area and it proves that normal expansion is a passive process. Normally work done is 0.3 to 0.8 kg meter per minute. kg meter per minute. No. And if you calculate the metabolic requirement, this is a minimal part, less than 1%. During exercise, whenever there is forced inspiration or expiration, and it is much more increased, oxygen consumption much more increases. Normally, at the resting condition, we are taking what amount of oxygen per minute? Then adapt. What amount of oxygen we are utilizing per minute? Oxygen কতটা নিচ্ছি আমরা? Oxygen কতটা নিচ্ছি প্রতি মিনিট? তাহলে আমি গতকাল আমি কি করেছিলাম? আমি চিৎকার করেছিলাম তাহলে সেটা আমার প্রশ্ন হয় না। It is my field, not yours. এটা আমারই ব্যর্থতা বলতে হবে। 250 ml of oxygen I am taking per minute from the nature. And delivering 200 ml of carbon dioxide. So the respiratory exchange ratio normally it is in a healthy individual is 0.8. So you can calculate or simply from basal metabolic rate you can calculate. You can compare this. Then you convert into calories. Your knowledge of physics is much more than me, and your memory is fresh. And so that you can easily calculate. You can convert this kg meter into calories. Convert them into joules. And then you can convert it into calories easy. And you can compare with that of the calories. There is a basal metabolic rate, and it is minimum fraction. During exercise, even 3% of energy is consumed. 97 for the exercising and other purposes. But in disease condition, suppose an individual suffering from asthma, they have wheezes. শ্বাস ছাড়তে পারছে না, হয়তো তোমার পাশে বসে রয়েছে কি জার্নি করছে, সেখানে তোমার সহানুভূতি হবে। You add when you are running stethoscope, you will get wrong time. That is called wrong time. And wheezes that you can the patient can listen, and anyone sitting nearby they can also have this experience. এবং আমি মনে করি অনেকে নিশ্চয়ই দেখেছো, আমার ইউনিতে যখন হাঁপানি অ্যাটাক হয়, কেউ না কেউ দেখেছো না, নিশ্চয়ই কেউ দেখেছো, দেখবে তারা বসে squeeze. Now, whenever there is respiratory distress, and in that condition, huge amount of energy can be required. In bronchial attacks of bronchial asthma, ventricular failure, severe pulmonary congestion, and in that case, there will be distress. And then it is much more. And in that case, you will find this elastic part is constant, and then it is increased. And expiration is an active process, more active process. It active process in that sense, then it will increase. So that the elastic force is not sufficient. So extra force is required. And so this respiratory muscles coming into action. And in this way, inspiration and expiration in normal condition, and when they are exercising, they are taking place. But the energy consumption is less. Time is almost over. So next day we will discuss something about the relaxation pressure balloon car. Relaxation pressure balloon car, and also some other aspects related to this serpentine action. So another day is required to complete this mechanics of respiration. Another day.
Okay, so this is practical session. First practical session, proper. Yesterday in practical session, I have briefed you the practical curriculum, right? Human practicals, amphibian and mammalian practicals, and hematology, right? Now, it is the usual dictum to start with hematology first, but as we don't have the actual student strength, right? We are starting with human practical. Okay, that's because this one can be repeated as well, right? Okay, so today's topic is determination of blood pressure in human using an aneroid sphygmomanometer, right? Determination of blood pressure by using aneroid sphygmomanometer, right? Okay, so what is aneroid sphygmomanometer? Any idea? How many types of sphygmomanometer you know? Okay, marker sphygmomanometer? Yes. You have seen? Yes. Aneroid sphygmomanometer, the dial one. Okay. Aneroid sphygmomanometer and what else? Digital sphygmomanometer and what else? Okay. So there are so many. We'll be discussing one by one. So determination of blood pressure using aneroid sphygmomanometer. It is one practical that comes under cardiovascular system, and also it has got competency. It has got one certifiable competency. So we have discussed what is certifiable competency. You should be competent to measure blood pressure anywhere outside this organization and also in this organization. And once you have passed the competency, it is considered that you are competent enough to perform this anywhere in the world, right? Okay. So determination of blood pressure using aneroid sphygmomanometer. Let us begin. So what is the aim of today's practical? The aim of today's practical is to measure blood pressure using a sphygmomanometer, aneroid one simply. Okay. So what is our learning objective? Our learning objectives are, first, after this session, you will be able to measure blood pressure by palpatory method, by auscultatory method, and not only measurement, as you are going to be a clinician, a doctor, you should be able to interpret it clinically, right? So not only the values, you have to correlate the values clinically, right? Okay. So next is to tie the blood pressure cuff properly around the arm of the subject. So we have some rules how to properly tie the cuff around someone's arm, right? And the third learning objective is to detect the appearance and disappearance of Korotkoff sound. What sound? Korotkoff. Okay, mind is spelling Korotkoff sound by placing a stethoscope on the brachial artery while measuring blood pressure. Okay, I'll be explaining what is Korotkoff sound. Okay. So the principle of measuring blood pressure by a sphygmomanometer, it involves balancing of air pressure against the pressure. Balancing of air pressure against the pressure of blood in the brachial artery. The air pressure being estimated by a marker sphygmomanometer in marker sphygmomanometer, and a mechanical system of metal bellows in aneroid sphygmomanometer. Okay? So blood pressure is balanced by the mercury pressure. Blood pressure is balanced by the mercury pressure in case of mercury sphygmomanometer, and a series of metal bellows, pressure within the series of metal bellows within an aneroid sphygmomanometer, right? Okay, so we are basically measuring the air pressure within the cuff, okay, and that pressure is balanced with the blood pressure, right? Okay. are the apparatus? Apparatus are the aneroid sphygmomanometer, one stethoscope, and chair and couch. Right? So these are the requirements. Okay. So you can see on your screen the aneroid sphygmomanometer first, and second one is mercury sphygmomanometer. Right? Okay. Now, in any blood pressure equipment, whether be it aneroid sphygmomanometer or mercury sphygmomanometer, we have a cuff. Okay, we have a cuff that we tie around the patient's arm. Right? We tie it around the patient's arm. Now, inside this cuff, we have a fabric, and inside that fabric, we have, a bladder. You have seen football bladder? Yes. So just like football bladder, we have a bladder inside the fabric. Right? Give me that BP machine. Take a step. I will do it right now. Okay. So we have this cuff. So this one is the blood pressure cuff. Okay. So what the measurement written over here, it is not the measurement of this cuff, rather the bladder inside. Why are you sitting there? And we are going to be a doctor. There might be a surgery for 6 to 7 hours long, and maybe even more. Practical classes, demonstration classes, you are always required to see it from the front, maybe in standing position. Okay? So get ready for that. Any practical session, any practical demonstration, and mostly the practical session, what you will be performing. Okay? What you will be performing, it is required for you to see all of these things standing. Okay? In the theoretical class and only in the demo class, you will be allowed to sit. Okay? This one is practical. You are supposed to do it yourself. Okay? You are supposed to be involved in the procedure. Whatever is being done over here, you are supposed to take this. You are supposed to examine this, see this. Okay? So it is totally interactive, and you are not supposed to see all this, right? And also in your future, those who are going to be a surgeon, there might be long surgery, and you should be performing it standing, right? Okay, so this is the cuff. Okay, this is the cuff, this is the tube, and we don't have aneroid sphygmomanometer over here. And my suggestion to all of you, if you procure your own blood pressure machine, do purchase an aneroid one. Okay, for practicing purpose. Okay, for practicing purpose, you purchase one aneroid. It is easily available in any online shopping, Amazon or Flipkart. So you just order it. Okay, it's less than $1,000 available, right? So you can purchase that. Okay, so this is the cuff. This is the cuff, and the cuff size written over here. All these cuff size are actually this is conventional, and throughout the world, that rule is followed. That how much cuff size is to be used for which individual, right? So this is the cuff or fabric, and inside this cuff, we can't see this. We can't see this. Inside this cuff, there is a bladder. Okay, inside this cuff, there is a bladder. Mostly it is green color. So we can't open it because in some machines there is option to open the bladder, but that option is not over here in that machine. Had it been available, I could show you. So anyway, so inside this fabric we have a bladder. I can feel this. The bladder is inside. I can feel this. Okay. So you see this. So it's the bladder inside, and all the dimensions written over here is the dimension for the bladder and not the fabric. Okay, the dimension of the bladder and not the fabric, right? So standard for most adult, it is 12 into 26 centimeter, and obese adult it might be 12 into 40 centimeter. For newborn 4 into 8, infant 6 into 12, and child 9 into 18. Okay. So all these measurements, actually, all these norms are given by AHA and European Society of Hypertension, ESH. Okay, European Society of Hypertension. Actually, throughout the world, we follow the guidelines made by ESH and AHA together. Okay, AHA is American Heart Association and ESH is European Society of Hypertension. Right? So all these two organizations, they usually publish guidelines for managing cardiovascular diseases as well as all the norms. Right? So you can always go to ESH website, American Heart Association website, AHA website, and you can check all the details. Okay. So blood pressure cuff, bladder. Okay, inside bladder, the dimension is this. You don't need to remember right now the pediatric values. Just see, but definitely do remember the standard size, that is 12 into 26. You might be asked the question for answering this one, standard for most adults, 12 into 26. So this value I want you to remember, right? Okay. Next, procedure, how to measure blood pressure. So we have two methods of measuring blood pressure. One is palpatory method and another is auscultatory method. Okay, one is palpatory method, another is auscultatory method. For palpatory method, we don't need the stethoscope. Okay, for palpatory method, we don't need the stethoscope, and for auscultatory method, we need the stethoscope. So first, let us discuss the palpatory method. Okay, so it must be in the sitting posture. Palpatory method, it must be in the sitting posture, right? Okay, someone will come forward. You come forward and sit. So the dictum is always stand at the right side of the patient. Okay, stand on the right side of the patient, and you may measure at left side or right side, but mostly it is advisable to measure it on the left side. Okay, because you know from your anatomy that left subclavian artery is a direct branch. Okay, left subclavian artery is a direct branch, but right subclavian artery is not a direct branch. But anyway, for your convenience in the clinic, you can measure in any arm. Okay, so what will be the difference? I will tell you later on. So give me the cuff. Okay, so there are some precautions. So what are the precautions? We will not be doing very ideal over here, but I will be demonstrating what are the ideal conditions. Okay, so ideal condition is you should take care that the patient was for at least for 5 minutes rest. Okay, and before measuring blood pressure within 1 hour or 2 hours, patient might not have coffee or tea or any such drink, right? Smoking, definitely, these are to be avoided before measurement, right? So this is one point, patient should be resting for at least 5 minutes. And second is, next is arm should be exposed. Okay, so arm exposure is a major point because many times in the clinic sometimes it's not possible, and patient should be having loose clothes, and while rolling the sleeves of shirt, it should not be lowered in such a way that it constricts over here. Okay, so you should remember that. So if I roll in this way and ultimately finally it constricts over here, it will hamper with the blood pressure measurement. Okay, I am telling you the ideal situation. I will not be doing all the ideal situation over here, right? Okay, so ideally, because your examiner will be asking you what are the precautions to be taken during blood pressure measurement, right? Okay, then you should feel the brachial artery. Okay, you should feel the brachial artery over here, right? And so first you palpate the brachial artery. Okay, I am not doing the ideal condition, but I am telling you the ideal condition. Arm should be exposed, right? So right now I will tie over the shirt. This is not ideal. Okay, it should be exposed. Okay. So tie the cuff in such a fashion that it should not be too tight or it should not be too loose. Okay. It should not be too tight or it should not be too loose, right? And remember that how to do it. It should not be too tight or too loose. 2 fingers you can introduce inside. Okay. With a little effort, you can introduce 2 fingers inside. So this is the dictum you should take care of, that it should not be too tight or too loose, right? Okay. As we don't have any sphygmomanometer right here, so we'll just be describing the procedure. So put your fingers for palpation of the brachial artery. Okay, palpation of the brachial artery, and with the underlying sphygmomanometer. This is not for learning. Okay, so you have the hand pump. Okay, you have the hand pump in case of. Okay, let me. Yes. So the inflator, the pump or inflator, I have in my hand. So I will raise it in calculatory method. So we don't take stethoscope right here. So I will raise it. I am feeling the brachial artery. Okay. So brachial artery is calculated. Now I will move it to radial artery. Okay. So I am feeling the radial artery. Okay. I am palpating the radial artery. So I will now inflate. I will now inflate it. So I have the pump. I will inflate it, inflate it, and at some point the pulse will descend. Okay. And I see on the dial that it is at 120 same pulse descends. Yes. Okay. So I will raise a little bit, 20 more. So I will raise it till 40. I will raise it to 140. Okay. I will raise it to 140. Now slowly, 2 to 3 millimeter per second, 2 to 3 millimeter of mercury per second, I will lower down pressure. Okay. So gradually I am lowering down, So this one you have to practice, because suddenly most of the students what they do is they unscrew the button so quickly that pressure suddenly falls. Okay. So this control you should practice. Okay. Once you have your own personal BP machine, you are advised to record it for your friends, for your family members, right? So practice is as many times as possible. So I will raise it up to 140. Then from 140 I will reduce gradually. Now suddenly at a point pulse appears. Okay. So it is the patient's systolic location. Okay. So the point at which pulse appears is systolic location. Okay. So this is palpatory method, and in palpatory method we can only determine the systolic blood pressure, and diastolic blood pressure cannot be measured. Okay. Then what is the significance of palpatory method? Why do we do it? Okay. So we gradually discuss. Now come to the auscultatory method. Give me one stethoscope from here. Because there are many patients who will brachial artery pulsation now, you can't expect that you will get radial artery. অনেক ডিজিজ আছে, যেমন কোয়াফেকশন অফ অ্যাওর্টা আছে, পড়বে তোমরা সাপ্লিমেন্টারি আর্টারিতে কোনো প্রবলেম হতে পারে। Okay, it is for teaching purpose. One will be by student and okay. 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 So now we are moving to auscultatory method. Okay. We are moving to auscultatory method. So for auscultatory method, we need the stethoscope, right? For auscultatory method, we need the stethoscope. Again, the initial procedure is same. Coffee drinking नहीं चलेगा, चाय नहीं चलेगा, ठीक है? Initial procedure is same. 5 minutes should be minimum 5 minutes should be resting period, right? Minimum 5 minutes should be resting period, and next, hand should be exposed properly. And यहाँ पर और भी कुछ problems हैं, that is the patient, there should be a backrest for the patient. Okay, there should be a backrest for the patient, and arm should not be hanging. Okay, arm should not be hanging while measuring blood pressure. This is not done. Okay, arm should rest on the table, right? Arm should rest on the table, and blood pressure cuff should be at the level of heart. Okay, blood pressure cuff should be at the level of heart. Okay, so this is over here. Okay, so these are all the precautions. Precautions are same for both palpatory measurement and auscultatory measurement. Palpation means feel for, right? And auscultation means to hear. So auscultatory method we will use the stethoscope. But we don't need to feel the radial pulse over here. Okay, so we will put the stethoscope. So again, I will inflate, and we will raise the pressure at a point where no sound is audible. Okay, so just say assume at 120 millimeter of mercury, sound disappears. Okay, sound disappears, and I will raise it 20 more. So up to 140 or up to 140 or 150 I can raise. Okay, then I will gradually reduce. Okay, and this diaphragm, one precaution is there. You put the diaphragm over the brachial artery. Okay, you feel the brachial artery and put the diaphragm over the brachial artery. Okay, and you know this knob is here. Okay, have you seen this knob is here? One for the diaphragm and one for the vein, right? So you should beforehand check that it is rotated towards the diaphragm. Okay, so if we tap it, we can listen the tap at my ear, right? Okay. So once it is done, you put the diaphragm on the brachial artery. Okay. We tap the so smart situations. Right. So we put the diaphragm over the brachial artery, right? Then we will raise up to 150, and gradually we will reduce. Okay. So मतलब मैं इसके लिए 150 तक रेज कर रहा हूँ. अगर किसी का 150 में साउंड आ रहा है तो मैं उसके भी ऊपर 20 को 170 तक रेज कर रहा हूँ. Okay. So up to 150 I have raised in this patient because at 120 sound disappeared. Okay, and above that I have raised it to 140. Now I will gradually reduce. Now suddenly at a point sound will appear. Okay, sound will appear. That point is systolic pressure. And again I will continue to lower down pressure by unscrewing the inflator. Okay, and at a point the sound will disappear. That point will be diastolic pressure. Okay, so তোমরা যারা শুনছো তাদের জন্য আমি স্টার্ট করে দিচ্ছি. শুনতে পাচ্ছ সাউন্ড? শুনতে পাচ্ছ? তাহলে সাউন্ড এখানে শুরু হবে, বন্ধ হয়ে যাবে. সাউন্ড এখানে শুরু হবে, সেটা হচ্ছে সিস্টোলিক প্রেসার, আর সাউন্ড হবে সেটা হচ্ছে ডায়াস্টোলিক. ঠিক আছে? হ্যাঁ, তাহলে সাউন্ড এখানে শুরু হলো, কোটা কত আছে দিস ইজ নট you are here to learn how to measure blood pressure in a proper. Okay, তাহলে auscultatory method, palpatory method and auscultatory method clear to you? Yes, right? I will allow you last half an hour time to listen all these sounds. ঠিক আছে? এখন তাড়াহুড়ো করার কিছু দরকার নেই. Okay, you have so many things to learn. Sir, I'll come. Which method is better?
Sir, আপনি স্টার্টে বলেছেন কারো একটু বেশি প্রেসার অবধি দিয়ে দিতে হয়, যাদের 1
যদি hypertensive patient হয়, ঠিক আছে? তুমি যখন ইনিশিয়ালি রেস করছো সাউন্ড শুনতে পাবে একটা জায়গায়, এবার তোমাকে ততটা তুলতে হবে যেখানে সাউন্ড ডিসঅ্যাপিয়ার করে যাচ্ছে, তার থেকেও 20 বেশি তুলতে হবে. ঠিক আছে? Okay, don't ask questions right now. I'll allow you questions. I'll take your questions. But when I complete this, all questions will be answered automatically, right? Okay, sorry, এটা ভিতরে ফিল করেছো একটা ব্লাডার আছে. Okay, so all the dimensions that was written over here is for the bladder, not the outside fabric, right? The dimensions are for the bladder. Okay, and remember this will be 26. Okay. Now the precautions, I am repeating all the precautions. The cuff should be tied over the brachial artery. The cuff should not be either too loosely or too tightly tied. At least we should be able to insert 2 fingers inside. The pressure should fall at 2 to 3 millimeter of mercury per second. Very slow. Please control. You have to adopt. You have to practice a lot for controlled deflation, for controlled reduction of pressure. Right? Okay. Now, yes. So again, this chart, it is according to 2018 guideline, and we are still following this 2018 guideline. Everything is written. You can also see the website of American Heart Association and European Society of Hypertension, right? Okay, so we divide blood pressure in terms of optimal, normal, high normal, grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, and finally isolated systolic hypertension. Okay. And this is clinically very relevant. You need to remember that, and in your future also, because we are still maintaining the 2018 guideline. Because after that, no fresh guideline came from these 2 organizations, American Heart Association and European Society of Hypertension. So we are still following this. Maybe during your professional life, there might be some new guidelines. But for now, this is the guideline we are still following, right? So categorizing patients depending on his or her blood pressure, right? So this is the categorization, and you need to remember. So optimal is less than 120, less than 80, remember. Okay, this is optimal. So above normal is optimal, right? So optimal, then normal, then high normal. Then we start the category of hypertension, grade 1, 2, 3, and isolated systolic hypertension, where it is the high normal. You just be cautious. Advise the patient for lifestyle modification, for salt restriction only, right? Then from grade 1 hypertension, we start medications, right? So this is the norm. I will discuss later on how to treat hypertension. That is a separate thing. And beyond physiology, we will be studying every detail how to treat hypertension in medicine as well, right? Okay. So remember all these values. I remember. Okay. This much I remember. Okay. So this much I remember because I need. Okay. So now 2 important things, that is white coat hypertension. So office BP in the hypertensive range, but out of office BP in the hypertensive range, but out of office BP not in the hypertensive range in patients not taking antihypertensive medication. Okay. Doctor के देखी calculation होगा blood pressure देगा, so white coat hypertension. So patient is normally not hypertensive. It very frequently happens. So the diagnosis of hypertension by categorizing the patient as type 1 or stamping the patient as type 1 or grade 1 hypertension or grade 2 hypertension, you should be cautious that it should not be white coat hypertension. मतलब एपोलोमेटिक hypertension रहेगा. Then masked hypertension, out of office BP in the hypertensive range, with BP not in the hypertensive range when desert in the office. Masked hypertension is more common among certain subgroups of population, including those having diabetes mellitus, chronic kidney disease, and obstructive sleep apnea. So mostly it is the neurological involvement when autonomic nervous system is involved due to long-standing diabetes. It happens masked hypertension. So it is again a point that need to be addressed. Okay. Now in your practical session, you will be provided with a sheet with a soft copy. Then you should print it and do your own practice and record the recordings over here. So you should record the systolic blood pressure, you should record the diastolic blood pressure, the pulse pressure, and you need to calculate the mean arterial blood pressure. Okay. So maintaining all the precautions, that making rest for the patient for 5 to 10 minutes, then avoiding tea, coffee, alcohol, right? Then all the precautions like back rest at the chair. Arms should not be hanging, okay. Then short sleeve should not be rolled in such a way that it constricts someone's arm. Then not too tight or not too loose the cuff binding, right? You must be able to allow. You must be able to insert 2 fingers inside, right? Yes. Now put the veil of this, not veil, diaphragm of this over the brachial artery, okay, and slow inflation at the rate of 2 to 3 millimeter of mercury per second. So maintaining all these precautions, you should be measuring 3 records and fill this up. Okay, so it comes in your competency. Next we have some questions. So before proceeding to questions, I have some. So it is BP measurement students logbook. You should print this. I will give you the soft copy. You should print it, and during practical session, you need to put the values. So we don't have patients right now, so you will measure, make a pair. Okay. So make pairs among yourself and measure each other's blood pressure, right? Okay. So next, you will be scored in this way. Okay. So conducting the performance of skill and knowledge of skill. Okay. Then there will be signature of your practical teacher, and this is the competency. Okay. So competency points are just the checklist that your teacher will check. Okay. So these are the checklists. Stand on the right side of the subject. Check for yes, very much important. Check for zero reading on the analyzed sphygmomanometer. Okay. So you need to calibrate it. If it is not at zero, okay. If it is not at zero, you need to calibrate it. Okay. Very often we do approximation in health setup, many government setup, mercury manometers or manometers. Sometimes, very often it is found that the reading is not at zero. Then we need to subtract or add sometime, right? Okay. So expose the arm up to shoulder. Wrap the cuff firmly about 2 point. Okay, another important point. Antecubital fossa is this one. Okay, antecubital fossa. So just 2.5 centimeter above the elbow crease. Okay, this is the elbow crease, and just 2.5 centimeter above the elbow crease should be the lower quarter of the cuff. Okay, this is another important point. Check that the cuff is neither too tight or too loose. Record the blood pressure first by palpatory method. Okay, when in front of your examiner, you will be measuring blood pressure. First do it by palpatory method, and then go for auscultatory method. Okay, this should be done. Why? I will be explaining you. Okay, then ensure that the diaphragm of the stethoscope is functioning. It is not towards the vein, right? Okay. Then localizing the brachial artery and place the chest piece over the chest piece of the stethoscope over it. Place the earpiece properly into the ear. Okay, stethoscope has got a specific direction. Do you know? Do you know this? Okay. So see this. This is incorrect. This is correct. Okay. Okay. See. This is correct. It is directed medially and anteriorly. Okay, anteriorly, somewhat towards anteriorly. This is correct. Okay, this is not correct. This is correct. Okay. Okay. So this is the thing. Place the earpiece of properly into the ear with being directed forward and medially, right? Inflate the cuff around 30 mm mercury higher the reading obtained by palpatory method. Okay, तुम्हें palpatory method में जा systolic blood pressure पेचो. Palpatory method में जा systolic blood pressure पेचो ताकि 30 mm above की मिलो. In case of auscultatory method. पहले हम लोग क्या करेंगे? पहले palpatory method करेंगे, ठीक है? तो palpatory method हो जाएगा और auscultatory method में palpatory method में जा systolic blood pressure पेची ताकि 30 mm above की मिलो. ठीक है? ताकि तुम्हें आस्ते-आस्ते different करो, right? Okay, next is record blood pressure by auscultatory method and take 3 readings. And report the findings in proper format. Format is given, right? Now coming to questions. Okay, now we will measure blood pressure maybe at tomorrow's class. Okay, not tomorrow, maybe Monday. Okay, so now I will see. Okay, so everyone do move for the ठीक है demo right. So define blood pressure. What is the definition of blood pressure? Anyone? What is the definition of blood pressure? Yes.
So the pressure applied by the blood on the arterial wall is known as blood pressure.
Yes, this is the lateral pressure. Okay. So lateral pressure applied by the blood column on the inner wall of the blood vessel. Right? Lateral pressure. Now we have two components. One is systolic pressure, another is diastolic pressure. What do you mean by systolic pressure and diastolic blood pressure? Okay. So systolic blood pressure is the maximum pressure during ventricular systole. Okay. As the maximum pressure we record during ventricular systole. Okay, and the minimum pressure which we record in peripheral arteries. Remember, in peripheral arteries. Okay, so maximum pressure during ventricular systole that we record from peripheral arteries, like brachial artery. Okay, like brachial artery or radial artery. Okay, so the maximum pressure that we record during ventricular systole is called systolic blood pressure, right? And diastolic blood pressure is the minimum pressure that we record from peripheral arteries. From peripheral arteries is very much important. From peripheral arteries during ventricular diastole. Right? So these are the definition of systolic blood pressure and diastolic blood pressure. Correct? Okay. Now, say, so this is the heart, right? LV, RV. And outer axis from LV. Outer axis from LV. Right? Okay. Now, what we have measured with the help of a sphygmomanometer? What we have measured with the help of a sphygmomanometer? It is the direct blood pressure. Is it the direct blood pressure or indirect blood pressure? Indirect pressure. So, how to measure direct blood pressure? Direct? You put a cannula, insert it in the aorta and connect a manometer. Okay? Put a cannula, insert it in the aorta and connect a manometer. You get the direct blood pressure. What is cannula, sir? Cannula, simply cannula. Catheter, cannula, right? Okay? So put a cannula, insert it into the aorta, connect it to the manometer. Simply, we get the direct blood pressure. But will we do it? No. Because it is invasive. Okay. Because it is invasive. So we go for indirect measurement. But there are some situations when we need to measure blood pressure directly from the artery by inserting a cannula into the radial artery or the brachial artery connected to the manometer. We do it. Okay. But not at OPD setting, but not at what setting, but maybe at the intensive care unit setting. Okay, at the intensive care unit setting. Okay. So we can insert the cannula right at the generation of pressure, right at the point where pressure is generated. That is your LV. Okay. Because your LV is contracting and pumping blood to the systemic circulation. Okay. RV is pumping and moving blood to the pulmonary circulation. Right? But we are right now concerned with the systemic circulation, the LV. Okay. LV is pumping blood to the aorta. That aorta is ultimately going through subclavian artery, through brachial artery, through radial artery. Okay. And much more peripherally the digital artery. Okay, so heart, aorta, subclavian axillary artery, subclavian artery, brachial artery, radial artery, digital artery. Okay, all these are peripheral arteries. So if I wish to measure blood pressure directly, where should I put the cannula? In the digital artery? In the brachial artery? In the axillary artery? In the subclavian artery or in the aorta or directly into the heart? What? Aorta. Okay. Aorta. Not radial artery. Not radial artery. Okay. Let me explain. Let me explain. Okay. So artery, brachial artery, radial artery, digital artery, right? What is this? LV. Right? Aorta, subclavian artery, brachial artery, radial artery, digital artery. Correct. So forget digital arteries. So tiny that we cannot properly distinguish. Okay. So radial artery. You put the manometer, connect it, connect the cannula, then manometer. You get pressure 120, 80. For a normal individual. I'm just talking about a normal healthy individual, right? You put cannula in brachial artery, connect manometer, you get pressure. Correct? Just a minute. So next, again into the subclavian artery. What will be your reading? What will be your reading? Into the aorta. Into the LV. Getting? Okay. The reason being that during contraction, LV is generating maximum pressure. Okay? Now it relaxes. No pressure. Zero. Right? But what is happening immediately next to it? What is happening inside the aorta? That during diastole we are getting 80. What is happening? What is happening is called the Wind-Kessel effect. Do you know what is Wind-Kessel effect? Because arterial walls and particularly aorta, it contains elastic tissues, elastin, collagen. Okay. So once LV contracts, blood is ejected into the aorta, and immediately after that, this arterial wall stretches and it pushbacks. Okay, arterial wall stretches and it comes back, right? So this is called Wind-Kessel effect, and this contraction when arterial wall comes back, it happens during diastole, and that is generating diastolic blood pressure. Okay. Arterial wall, had it been devoid of elastic tissues, elastin and collagen, then everywhere blood pressure would have been 120/0. Right? So this is because of elastic recoil of the aorta, because content of elastic tissues, that is elastin and collagen, the content are highest in aorta. Okay. So this elastic recoil, it generates diastolic blood pressure. Okay. So the source of diastolic pressure, it is not into the heart. It is due to the elastic recoil. It is due to the elastic recoil of aorta. Everyone clear?
Yes, sir.
Okay. So what is the pressure inside left ventricle? 120/0. Okay. What is the pressure in the arterial system? 120/80. Okay? Clear? Okay. So this is all about systolic and diastolic blood pressure. Next question, what is written? Okay. systolic and diastolic blood pressure depends upon what are the factors. So we will talk about only the major factors on which systolic blood pressure depends. Okay, so systolic blood pressure, you know, it is the contraction. Okay, so it is the force of contraction. The more is the force of contraction, the more is the systolic blood pressure. Okay, the more is the ventricular contraction, the force of contraction, the more is the systolic blood pressure. Okay, so that is stroke volume. Do you know what is stroke volume?
The volume of blood formed by each ventricle per minute.
In a single contraction, yes. In a single contraction, the amount of blood ejected. Okay. Okay, so systolic blood pressure mainly depends on stroke volume. Stroke volume, force of contraction. Force of contraction is stroke volume divided by T. So stroke volume or force of contraction. Okay, as this is stroke volume, we are mentioning the word volume. So another important factor is volume. If someone's volume is less, we have explained what is extracellular fluid volume, what is effective circulatory fluid volume, everything. Okay. So if someone's volume is less, stroke volume should be less. Okay. If venous return is less, stroke volume should be less. Okay. So systolic blood pressure, it depends on within physiological limit two factors. One is ventricular contractility and another is volume status of the patient. Okay, volume status of the patient, and both of these two factors will regulate the stroke volume. Okay, so systolic blood pressure directly depends on the stroke volume. Now stroke volume depends on another two factors, that is patient's volume status, or you can say venous return, and another factor is ventricular contractility, myocardial contractility. Okay, myocardium or muscle has got three properties. I have just mentioned, explain for you. Three properties. You need to explain in detail, and we will take separate class for that. What are the properties of myocardium? Okay, so one is preload, one is afterload, and another is myocardial contractility. Okay, for any muscle, those properties are applicable in skeletal muscle as well. Okay, so preload, afterload, and contractility. These three parameters that drive all the functions of heart. Okay, so the more is the myocardial contractility, the more is the stroke volume. The more is the venous return, the more will be stroke volume. Right? Okay, so this is systolic blood pressure, and diastolic blood pressure, it depends on peripheral resistance. Okay, diastolic blood pressure depends on peripheral resistance, or we may also call it afterload. Okay, peripheral, another name of peripheral resistance, we call it afterload. So how to define afterload? It is the resistance. It is the resistance against which blood is expelled. It is the resistance against which blood is expelled. We will again discuss all these theoretical part in cardiovascular system theory classes. Okay. So the resistance against which blood is expelled, right? So just for example, brachial artery. Okay, make the brachial artery narrow. Okay. So this is the caliber of brachial artery. This is the caliber of brachial artery. You make it narrow. Okay, you make it narrow. What will happen? This contraction will get resistance over here. Okay, so we call it peripheral resistance. Okay, peripheral resistance. It is the resistance against which blood is expelled. The resistance against which blood is expelled. The more is the peripheral resistance, the more is the diastolic blood pressure. Okay, so diastolic blood pressure directly depends on peripheral resistance. Okay, if you apply some drug to the patient so that the patient's blood vessel smooth muscles are contracted. Okay, blood vessel, two states of blood vessel. One is vasodilation and another is vasoconstriction. Okay, so if you give some drug to the patient so that there is vasoconstriction, the peripheral resistance will increase. Okay, peripheral resistance will increase so that diastolic blood pressure will also get increased. Right? Clear? So systolic blood pressure depends on stroke volume and diastolic blood pressure depends on peripheral resistance. Okay? Clear everyone? And stroke volume again depends on volume, number one. Second is myocardial contractility. Clear? Okay. এবার আরেকটু জিনিস তোমাকে এক্সপ্লেইন করতে হবে, that is mean arterial blood pressure. What is mean arterial blood pressure? Okay, mean arterial blood pressure is very important at the ICU setting. Okay, we need to measure mean arterial blood pressure of the patient. So I have explained how to calculate mean arterial blood pressure. It is diastolic blood pressure plus 1/3 pp, DBP plus 1/3 pp, right? So DBP plus 1/3 pp. DBP is 80, pp is 1/3 of 40. That means 80 plus 13.3, 93.3. Okay, always mention unit. Always mention unit. Otherwise, your physics teacher will scold you. Okay. So mean arterial blood pressure 93.3 millimeter of mercury. Now we were talking about mean arterial pressure, tissue perfusion yesterday, right? Tissue perfusion, about tissue perfusion. So maintaining mean arterial blood pressure is very much essential to maintain tissue perfusion. Once it is less than 65, or once it is less than 65, tissue perfusion is usually hampered. So in the ICU setting, it is always our target to raise the blood pressure, to raise the blood pressure so that the mean arterial blood pressure is always above 60, above 65 or above 70, right? Otherwise, tissue perfusion will be hampered, right? So this is normal value of mean arterial blood pressure, 93.3, a normal exact value. But you know, in human being we have some range. Okay. So there are so many situations. Every time we pass through dehydration, volume up down. So our mean arterial blood pressure keeps on changing. Okay, mean arterial blood pressure keeps on changing, and there is a range. And this range is big enough. So within that, we can maintain our tissue perfusion. Right. So even at 70, 72, we can maintain sufficient tissue perfusion. But once it is less than 65, tissue perfusion is somewhat hampered. Okay. Now, can you please explain me why we have made this formula? Is it coming to your mind? Why diastolic blood pressure plus 1/3 pulse pressure? Why not diastolic blood pressure plus mean pressure? It's simply DBP plus SBP by 2. That is 120 plus 80 by 2 is equal to 100. Why not this? So we are calling it mean pressure. Mean is just average. So just add systolic blood pressure and diastolic blood pressure, divide it into 2. Simple.
So systolic blood pressure টা তো ভেন্ট্রিকুলার মধ্যে হচ্ছে না তো ওই জন্য কি
Anyone else?
Sir, systolic blood pressure মানে এটা তো mean arterial মানে artery মধ্যে যে প্রেসার করবে এবং diastolic is caused in the artery আর পালস প্রেসারটাও আমরা আর্টারিতে ইয়ে করি তো mean arterial blood pressure আমি লেফট ভেন্ট্রিকুলার কন্ট্রাকশনের প্রেসারটা কি করে রাখতে পারি তার জন্য আমরা সিস্টোলিকটা নিই না
So why 1/3? It might be half or it might be 1/4.
আমি গেস করব তো জানি না
সেটা তো আমি বুঝতে পারছি Anyone else? Okay. So, systole plus diastole. How much time is there? 0.8 seconds. So, cardiac cycle is 0.8 seconds. How much is systole and how much is diastole? 0.5 is systole. 0.3 is diastole. So 0.5 correct? Okay. Now, the thing is, আমি তোমাদের আগে তখন বললাম যে আমরা যদি আস্তে আস্তে একদম ডিজিটাল আর্টের দিকে মোর পেরিফেরালি মুভ করে দেব ঠিক আছে তুমি ম্যানোমিটারটা এখানে লাগিয়েছো তাই তো মানে আরো ভালো করে পুরো কনসেপ্ট তৈরি করো একদম পুরো কনসেন্ট্রেট করো নাহলে বোঝাতে কঠিন ওকে তাহলে এইখানে আমার 0 এখানে 120 রাইট তুমি যখন এলবি তে ম্যানোমিটারটা লাগিয়েছো ওকে যখন এলবি তে ম্যানোমিটারটা লাগিয়েছো তখন কি হচ্ছে তোমার গ্রাফটা উঠছে এরকম 120 0 120 0 120 হচ্ছে ওকে তারপর যখন এইখানে লাগিয়েছো ম্যানোমিটারটা লাগিয়েছো হ্যাঁ তখন কি হচ্ছে 0 80 120 ঠিক আছে তখন এরকম হচ্ছে ठीक है এক্স্যাক্টলি প্রেসারটা এরকম দেখতে হয় না অন্যরকম দেখতে হয় তুমি বোঝার জন্য বলছি ওকে এবার তুমি যত মোর পেরিফেরালি মুভ করবে ঠিক আছে রেডিয়াল আর্টারিতেও আমি এরকম 120 মুভ করে পেয়ে যাচ্ছি তারপরেও যত ছোট ছোট আর্টারিতে মানে ডিজিটাল আর্টারি আরো স্মল আর্টারি তারপরেও ক্যাপিলারি এই সব জায়গায় যদি আমরা মেজার করতে পারি না নরমালি অত টাইনি জায়গায় তো মাইক্রোম্যানোমিটার লাগাতে হবে মাইক্রো ক্যানুলা লাগাতে হবে ঠিক আছে experimentally possible but we do not do so the thing is the more we proceed towards the peripheral artery this fluctuation is less okay this fluctuation is less মানে মনে করো ডিজিটাল আর্টারিতে গেলাম ডিজিটাল আর্টারিতে গিয়ে সে 80 120 তখন ফ্লাকচুয়েশনটা কিন্তু এরকম হবে না ওকে ওই একটা মাঝামাঝি জায়গায় এরকম করতে পারবে আচ্ছা ঠিক আছে ওই ফ্লাকচুয়েশনটা তুমি দেখতে পারো because the pressure wave it is dissipated right ওই ফ্লাকচুয়েশনটা পাবে না তুমি যদি একদম টিপে চলে যাও সেখানে গিয়ে প্রেসার মাপার চেষ্টা করবে ঠিক আছে তাহলে দেখবে এই জাস্ট একটা লাইন এরকম যাচ্ছে ঠিক আছে তাহলে the more you move towards the periphery from the center from the heart you are moving distally what is happening this fluctuation is less okay and এই ফ্লাকচুয়েশনটা লেস হতে একদম টার্মিনালি তুমি যখন পাচ্ছো ঠিক আছে এই 120 80 একদম ডিস্টাল আর্টারিতে চলে গেছো সেখানে যখন মেজার করছো তখন ও একটা জায়গায় এরকম ফ্লাকচুয়েট করছে এই আসছে এবার এই যে ভ্যালুটা এটাই মিন প্রেসার এটাই মিন প্রেসার ঠিক আছে এবার এই মিন প্রেসার তুমি সব জায়গাতেই মেজার করতে পারো ঠিক আছে মানে ডায়াস্টল আর সিস্টোলের যে ফ্লাকচুয়েশনটা সেটা অত পেরিফেরিতে খুব একটা কাজ করছে না তার জায়গায় একটা ফিক্স জায়গায় ও অসিলেট করছে ঠিক আছে সেই জায়গাটা হচ্ছে মিন আর্টারি প্রেসার ঠিক আছে তাহলে আমার থ্রুআউট দ্য সিস্টোল তুমি এই আউটাটা পাবো এবার ওকে জাস্ট থিংক অ্যাবাউট দিস আউটা সো থ্রুআউট দ্য সিস্টোল in this aorta it is maintaining 120 okay and throughout this 0.5 second this aorta is maintaining 80 किसका influence ज्यादा है diastolic influence ज्यादा है so we cannot just simply do it 120 plus 80 by 2 cannot be done because its influence is more diastolic's influence is more throughout 0.5 second had it been 0.8 had it been divided into 0.4 into 0.4 then you can do it it is diastole 0.5 right diastole 0.5 it is 0.3 so truly very accurately as you are a scientific person you just came from physics or chemistry so if you want to measure accurately the mean arterial blood pressure and the patient's cardiac cycle is 0.8 second okay patient cardiac cycle is 0.8 second that means systole is 1.3 and diastole is 0.5 so you should integrate 0 to 0.3 t dB plus 0.3 to 0.5 got the concept
yes
I don't know please okay nice and you will be gradually forget congratulations okay so concept of this property যদি कोई want to measure mean arterial blood pressure very accurately you need to integrate right but instead of integration it is seen that if you put this formula dBp plus 1/3 into SBP minus BBP. Okay, if you put this formula, you will be getting almost the value of integration. Okay, you will be getting almost the value that you derive from integration. Right? So this is why. So you can see from this equation. এটা করে দেখো না কি হচ্ছে তাহলে হচ্ছে dBp এটা কি হচ্ছে dBp plus SBP by 3 minus 1/3 dBp তাহলে কি হচ্ছে 2/3 dBp plus 1/3 dBp তাহলে dBp এর ইনফ্লুয়েন্স ज्यादा হচ্ছে না 2/3 dBp plus 1/3 SBP ক্লিয়ার বুঝলে তাহলে এইটা করলে মোটামুটি আমরা ওই মেইন ভ্যালুটা পেয়ে যাই because in bioscience, in medical science, in medicine physiology we don't need the accuracy just like this कि पॉइंट के बाद हमें 5 डिजिट लिखना है ऐसा नहीं ठीक है तो এইটা করে আমরা মোটামুটি তাহলে মেইন আর্টারি প্রেসারের কনসেপ্ট ক্লিয়ার হয়েছে সবার দিস ইজ মেইন আর্টারি প্রেসার ওকে ব্লাড প্রেসারে আমরা যে সাউন্ড জোরে জোরে পড়ো কি কোশ্চেনটা আছে Who is in front? What are Korotkoff sounds? Okay, what are Korotkoff sounds and what is oscillatory gap? What are Korotkoff sounds and what is oscillatory gap? Right? Korotkoff sound and oscillatory gap. So what are Korotkoff sound? যে সাউন্ডগুলো তোমরা শুনেছিলে ব্লাড প্রেসার মাপার সময় ঠিক আছে যে সাউন্ডটা ডিসঅ্যাপিয়ার করে গেল আবার সাউন্ডটা অ্যাপিয়ার করলো সেই সাউন্ডটাকে আমরা বলছি Korotkoff sound ওকে সাউন্ডটা কেন হচ্ছে genesis of this sound what is the cause of genesis of this sound you are constricting what artery brachial artery you are constricting brachial artery by inflating it okay by inflating it you are constricting brachial artery so the brachial artery lumen the caliber will constrict okay brachial artery caliber will reduce right cross section of the brachial artery it will reduce okay so once the brachial artery caliber is reduced what will happen peripheral resistance is there but it is externally we are applying pressure okay externally we are applying pressure and finally at a certain pressure the lumen of brachial artery is occluded completely there is no blood flow okay and the sound disappears okay this is the mechanism while measuring blood pressure so you are inflating brachial artery is getting narrowed and blocked
তাহলে তো স্যার লং টার্মে ওটা ড্যামেজ করছে
লং টার্মে তুমি ব্লাড প্রেসার কাপ নিয়ে করে রাইজ করে রেখে দেবে পেশেন্ট okay so patients hand will be ischemic right patients hand will be ischemic and if you raise the pressure and if you raise the pressure you tighten it and forget it for 5 minutes the patient will be just slapping so I am inflating brachial artery is getting narrowed and ultimately it is occluded right and once it is occluded no sound heard okay once it is occluded no sound heard right no sound heard so say इसका प्रेशर मेजर करा था मैं तो at 120 millimeter of mercury his brachial artery got occluded okay brachial artery got occluded okay no flow beyond that no blood flow beyond that now I have raised even 20 more up to 120 or up to 150 I have raised right now I am gradually reducing it okay just at 120 millimeter of mercury what will happen it will slightly open okay it will slightly open and sudden rush of blood to brachial artery right so this rush of blood will cause turbulence okay this rush of blood will cause turbulence what is turbulence normally I'll teach you in your theory classes that normal blood flow is laminar flow okay normal blood flow is laminar flow so we have a blood vessel like that and it flows in multiple lamina okay flows in multiple lamina the central lamina has got the highest flow so The front is blade shaped and it is very smooth. There is no turbulence. Okay. Now once this turbulence happened, once this turbulence has happened, blood flow is irregular. It is very much irregular and chaotic. Okay. Blood flow is irregular and chaotic. This is called turbulence. Okay. So if you have traveled in aeroplane, so you have seen due to bad weather, the announcement is there that due to turbulence. Okay, so airflow is also laminar normally, but during the storm or bad weather, there is turbulence, haphazard flow of air in different directions. Okay, so during laminar flow, flight moves in a smooth fashion, right? Okay, so the similar thing happens over here, that whenever there is turbulence, due to turbulence, some sound appears. Okay, and this sound is called your Korotkoff sound. Okay, this sound is called Korotkoff sound. Because you are quite novice right now, gradually you will be seeing that while measuring blood pressure, so just for his case, so at 120 millimeter of mercury, the brachial artery just opens up and creates a big turbulence. Okay, creates a big turbulence. So the initial nature of sound is tapping sound. Tack, 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 tack. It's a tapping sound. Start of the initial. Okay. So first is tapping. All are turbulence. All are turbulence. So until and unless we are completely deflating, the cuff, turbulence will happen. Okay. So brachial artery इसका normal caliber में जब तक वापस नहीं जाता है तब तक ये turbulence होता रहेगा. ठीक है. And throughout the time period, there will be Korotkoff sounds. Okay, and the nature of these Korotkoff sounds, it changes. Initially it is tapping. Okay, initially it tapping and gradually it will become softer. It will become softer. So initially it's tapping, then we call it squeezing. Okay, then twist, then muffle. Right? So tapping sound, squeezing sound, twist sound, muffle sound, all are Korotkoff. So we call it phase 1, phase 2, phase 3, phase 1, phase 2, phase 3 and phase 4. Okay, so how many phases of Korotkoff sound? 4 phases. 4 phases. Okay, tapping, squeezing, twist, muffle. Tapping, squeezing, twist, muffle. So these are 4 phases of Korotkoff sound. Okay, so now there is a big confusion that normally for all practical purpose we consider that disappearance of Korotkoff sound is diastolic blood pressure, appearance of Korotkoff sound in auscultatory method is systolic blood pressure, right? Now there is a confusion. Some group of physicians, they consider that disappearance of Korotkoff sound is the point that we record for diastolic blood pressure, and some group of physicians, they tell that no, not the disappearance, it is the point of muffling. Okay, when phase 4 starts, okay, when phase 4 starts, the point of muffling is the diastolic blood pressure. So there is a big confusion. We are not going to the controversy, but most of the clinicians or doctors, they prefer that yes, muffling is the point of diastolic blood pressure. Okay, but for your practical purpose, do not go for muffling. Please do not go for muffling, because it will not be possible for you to accurately pinpoint the point of muffling. Okay, it's too much impossible. Even for myself also, right? Even any big cardiologist or anyone, from point of muffling, understanding the point of muffling is very difficult. Okay, even you see 1,001 lakh patients, then also it will be very much difficult, right? So point of muffling, just forget point of muffling. For all our practical purposes, we consider that the disappearance of Korotkoff sound is diastolic blood pressure, right? Okay. So from your practical point of view, during your practical, you will be asked questions on Korotkoff sound. What are the causes of Korotkoff sound? What are the phases of Korotkoff sound? What are the points of systolic blood pressure and diastolic blood pressure? Okay, then you should answer in this way. Okay, I guess if all of you can answer right now, what is Korotkoff sound, what are the phases of Korotkoff sound, what is the point of systolic blood pressure, and what is the point of diastolic blood pressure, right? And what is systolic blood pressure definition, what is diastolic blood pressure definition, what are the factors that systolic blood pressure depends upon, what are the factors that diastolic blood pressure depends upon, right? So all these questions answer to you, right? Okay, now what is auscultatory gap? What is auscultatory gap? Korotkoff sound is not hard. Okay, Korotkoff sound is not hard. Okay, so it mostly happens in hypertensive individuals. Blood pressure খুব বেশি থাকে. Okay, maybe grade 3 or grade 4 hypertension or isolated systolic hypertension. Okay, so what happens in these cases? The blood vessels are atherosclerosis. Do you know atherosclerosis?
Yes, sir.
It's not hard. Okay, we will be studying atherosclerosis in detail, and many things we will be studying in pathology as well, right? So for now, atherosclerosis is a disease process where blood vessels are stiff, atherosclerosed. Blood vessels are sclerosed. There are deposition of cholesterol and foam cells are formed. So there are so many pathologies. LDL, LDL, everything is there. So a big disease process is there. Okay, so atherosclerosis, right? So in atherosclerosis, as the blood vessels get sclerosed, okay, blood vessels get sclerosed, this Korotkoff sound is not transmitted, okay, and spuriously, or you determine a blood pressure that is lower, and you miss the patient of hypertension. Right? So you determine a blood pressure that seems to be normal, but there was an auscultatory gap. Okay, there was an auscultatory gap, and falsely you determine a blood pressure which is less. Right? So this is auscultatory gap. Now, how to overcome this problem? How to overcome this problem? So what happens in case of auscultatory gap? While you are reducing or you are deflating the cuff, what happens? Korotkoff sound appears quite late. Okay, Korotkoff sound appears quite late. Say Korotkoff sound shuru hona tha 170 mein and it started at 140. Right? It started at 140. So this is why while suspect patients, old aged patients, you are suspecting that the patient might have atherosclerosis or some disease process like that. Okay, so you should do a palpatory method first, because in palpatory method you are not depending on any sound. Okay, you are just palpating. You are just palpating the radial artery. You raise the blood pressure above systolic blood pressure. You are reducing. Suddenly you got the blood pulse. It is your systolic blood pressure. It is the patient's systolic blood pressure. This is the importance of doing palpatory method. Just few minutes back, someone was asking, then why do you do systolic palpatory method? Because in auscultatory method, simultaneously we get the systolic blood pressure and diastolic blood pressure. So what is the value of doing palpatory method? This is the value of doing palpatory method. You correctly diagnose a patient of hypertension having atherosclerosis simultaneously, right? Clear? So this is auscultatory gap. It is very favorite question for the examiners, be it in physiology or be it in medicine. They will ask you what is auscultatory gap. Now next is what are the factors that affect blood pressure? Again, theoretical part. What are the factors that affect blood pressure? Most important individual risk factor is obesity. Okay, most important individual risk factor is obesity. Then gender or sex. Males are more prone to develop hypertension. Then some dietary habits. Some dietary habits like high salt intake. Okay, high salt intake may be associated with high blood pressure. Vitamin D deficiency again associated with high blood pressure, right? And what else?
Caffeine.
What?
Caffeine.
That is temporary. Okay, if you take tea, caffeine, alcohol, alcohol intake, yes, alcohol, very much important factor. Chronic alcoholism. Okay, chronic alcoholism is another risk factor for high blood pressure. And most importantly, blood pressure runs in families. Okay, blood pressure runs in families. Genetic, so it is polygenic. Yes, multiple genes are involved, and one of the most important genes is alpha adducin gene. Alpha adducin. Alpha adducin gene is a very important gene. Yes, it is polygenic. Once it runs in the families, hypertension is polygenic. Multiple genes are involved, but one of the most important genes is alpha adducin gene.
So hypertension.
Yes.
Hypertension.
That's yes. What are you talking about? Okay. So these are the risk factors. These are the risk factors. We will start with obesity because it is the most important individual risk factor for increasing blood pressure. Then everything comes dietary habit, vitamin D deficiency, alcohol intake, diabetes. Everything leads to hypertension. And finally, Ostensibly, yeah. Once more. Okay, I'll okay. So let me finish all the questions first. Okay. So next question. Read out loud. Actually, one of your question. Okay, what is the most accurate method of measuring blood pressure? What is the most accurate method of measuring blood pressure? Put it cannula, insert it. Right. So it is I have asked you what is the accurate method of measuring blood pressure. Answer is direct method. If I ask you what is the most accurate invasive method, non-invasive method to measure blood pressure, then your answer should be something else. Okay? My question was what is the most accurate method to measure blood pressure? The answer is direct method, and direct method is an invasive method. Now my next question is which is the most accurate method to measure blood pressure in non-invasive way? Now you answer. Read out the question first very carefully. Okay, this is how your examiner will confuse you, right? So what is the most accurate non-invasive method to measure blood pressure? Answer? Okay. None of that. Okay, so the answer is oscillometric method. Okay, oscillometric method is the most accurate method to measure blood pressure. Okay, so non-invasive. Oscillometric method is non-invasive, but it is based on a principle. Oscillometric method we do not commonly use in OPD setting or output setting. Oscillometric blood pressure measuring machines usually available in high setups and also in the ICU it is available. Okay, oscillometric method. Mechanism or principle. Simply based on the oscillation. Okay, and this oscillation of the brachial artery, it is transmitted. Oscillation of the brachial artery. So you are picking the pulse, right? You are picking the pulse in palpatory method, and you are picking the sound in auscultatory method. Even before that, your brachial arterial wall starts to oscillate. Okay, so from the skin we can determine that oscillation. Okay, we can transduce it, and this mechanical signal is converted into electrical signal in a computerized way. Okay, and we measure from the computer, right? So this is oscillometric method. Simply a simple principle. Okay. I am not a physicist or engineer, so I can't give you big details. And you don't need to know being a doctor. Okay. So oscillometric, just know the principle, because principle is very important. So even for him, I told that at 120 millimeter of mercury, the brachial artery just opens up, and there is a spot of blood. Okay, even before that, the arterial walls start oscillating. Okay, so the fraction of second difference can be captured in oscillometric method. Okay, so once the arterial wall starts vibrating, it can be captured, that signal can be captured and converted into electrical signal, and we get it from the computer, right? So this is the principle of oscillometric method. Omron 907. Omron 907. This is one model. This is one machine. Model, yes. Omron 907 is a machine that picks up oscillometric signal. So anyway, nobody will ask. Nobody is asking. Just what is the best method? What best? Not best. What is the most accurate method? Okay. Then what is the gold standard method? Mercury sphygmomanometer. Mercury sphygmomanometer, gold standard machine, right? Okay.
Gold standard.
Simply Mercury sphygmomanometer is the gold standard. Okay. Now how to diagnose blood pressure? How to diagnose blood pressure? Diagnose. Blood pressure कैसे diagnose करोगे?
ब्लड थिनिंग एजेंट देते होगे।
How to diagnose hypertension? How to scan the patient hypertension?
Diet, proper diet,
Excessive swelling.
So workout, sir.
High heart rate.
ECG.
Okay. Silent. You are a doctor. I am your patient. I came to you. And you measured my blood pressure as 160/90. Okay, 160/90. So, will you stamp me as a patient of hypertension?
No.
Or you need to do something else?
No, sir.
Something else. Diagnosis.
What else? I might be having this white coat hypertension. I might be having some. I might be having some big fight with my wife. Okay. I might be having some big stress in my workplace. Right? My HOD has scolded me. My principal has scolded me. So many things can happen. So I might have high blood pressure. So just a single point of time. You have measured my blood pressure as 160 and 90, and you prescribe me antihypertensive.
No, sir.
Okay. Then how you stamp me as hypertension? Yes, I might be a patient of hypertension. I might have chronically blood pressure 160/90. Okay. But I might have some other issues as well.
White coat full cover check.
So to diagnose hypertension, a single point of time measurement of blood pressure will not tell you, will not guide you to stamp a patient of hypertension as hypertensive, right? So to diagnose hypertension, we need to do 24 hours ambulatory blood pressure measurement. Okay. So it's a portable device. The patient can wear it and patient can do all his day-to-day activities, go to office, and every day-to-day activities, right? And finally, after a few days, we detach the device, we connect it to the computer, and we get to know the mean pressure throughout the day, right? So this is the way to diagnose a hypertensive patient. But you know, 24 hours ambulatory blood pressure device, it's a costly device. It's a costly device, and particularly in India, in rural setup, it's not available. Definitely, easily get to use, right? So we have only this marketed sphygmomanometer or this dial or Android sphygmomanometer, or maximum we will have this digital sphygmomanometer, right? So it is advisable that you measure multiple times, okay? So maybe in the morning, then in the evening, maybe throughout the day, 3 times you measure, okay? And at least follow up the patient for a period of 10 days, then you determine whether the patient is having hypertension or not. Yes, this should be done. But am I missing something? Yes, if the patient is having hypertensive urgency or hypertensive emergency. Hypertensive emergency is when blood pressure, systolic blood pressure is more than 80, and hypertensive urgency is when systolic blood pressure is more than 220. Okay, we call it hypertensive emergency or hypertensive urgency. Then you do not wait, definitely. Then you do not wait. Then you need to treat the patient immediately, because all hypertensive emergencies and hypertensive urgencies, they have a propensity to bleed. Okay, so arteries may rupture and may bleed anywhere, particularly in the cerebral circulation. Okay, so patient might have intracranial hemorrhage, right? Stroke, and finally stroke, right? Okay, so if the patient is having hypertensive urgency or hypertensive emergency, then you do not do any delay. Otherwise, if you measure blood pressure 150 by 90 at a single point of time, do not stamp the patient as hypertensive. Follow up the patient and ask the patient to maintain a diary and measure blood pressure somewhere, wherever possible. Okay, at least twice a day, in the morning and in the evening, and come back after a week, right? And in the meantime, you ask the patient for lifestyle modification, salt restriction, right? And few exercises as well, if possible. Okay, so to recap, most accurate method to measure blood pressure, direct method. Most accurate non-invasive method is sphygmomanometer. Gold standard is marketed sphygmomanometer. Why marketed sphygmomanometer? Because dial वाला जो Android sphygmomanometer है, उसका metal बिल धीरे-धीरे जब gold होता है तो थोड़ा सा लूज हो जाता है, spring action. Okay, so initially ठीक है. So gold standard is marketed sphygmomanometer. And for diagnosis of hypertension, 24 hours ambulatory blood pressure monitoring. Okay, 24 hours ambulatory blood pressure monitoring. Okay, 24 hours ABPM, ambulatory blood pressure monitoring device. 24 hours ambulatory blood pressure monitoring device.
Sir, blood pressure যদি ফল করে যায় তাহলে
কি হবে? মিন আর্টারি প্রেসার ফল করবে, সেরিব্রাল পারফিউশন হবে না, আনকনসিয়াস হয়ে যাবে। ঠিক আছে? ওকে, হাইপোটেনশন তো ডিসকাস করছি না এনিওয়ে। ঠিক আছে, তাকে তো ফ্লুইড দেওয়া যাবে, অনেক ব্যাপার আছে। ঠিক আছে, ফ্লুইড দেওয়া যাবে, তাকে ফ্লুইড দিতে পারো। তারপরে ইনিশিয়ালি কি করবে? If suddenly someone gets hypotensive, ঠিক আছে, যেমন এই anatomy dissection হলে গিয়ে প্রথমে বডি দেখে অনেকে ভেসোভেগাল অ্যাটাক হয়, ঠিক আছে, ভেসোভেগাল অ্যাটাক হয়, মেয়েদের বেশি হয়, ঠিক আছে, কি হয় suddenly sudden fall and unconsciousness. Okay, sudden fall and unconsciousness. So this is called vasovagal attack. Vasovagal attack, we call it vasovagal attack. First কি করবে? First কি করবে? পরে First thing is leg raise. First thing is leg raise. Okay, তাহলে লোয়ার এক্সট্রিমিটিতে যে ব্লাড আছে সেটা টুয়ার্ডস হার্ট আসবে, you will be increasing preload, and preload increase करने से कैसे इस perfusion को बाद में बताऊँ, ठीक है? तो first maneuver is you raise leg, ठीक है? And second maneuver to the consciousness gain for it, take some oral fluid. That must contain salt, right? Take some oral fluid. Okay. তারপরে next option house যদি না হয় saline. Okay. তাতেও যদি না হয় যদি ICU and vasopressor, ঠিক আছে? Vasopressor, use some noradrenaline, okay? Use some noradrenaline or adrenaline or dopamine, right? We have many drugs for this blood pressure. Okay. So we are not discussing hypertension, right? Okay. Last one thing that is remaining. Okay, Barnum is this one. अच्छा এখন পর্যন্ত ব্লাড ডিসকাশন হলো এই কোশ্চেন বা বুঝতে কোথাও অসুবিধা
Sorry, gas
Sir, oscillatory gap type oscillatory gap type
Okay, oscillatory gap it usually happens in very old hypertensive individuals who are also suffering from atherosclerosis. So what happens? When the brachial artery, you are occluding brachial artery, right? You are inflating, and the brachial artery is occluded. Now, while deflating, when first brachial artery opens up a little bit, first opens up, then there is part of blood, and there should be one Korotkoff sound. You should listen a Korotkoff sound, right? But you don't listen. Okay, Korotkoff sound is not heard, even if the brachial artery has opened up. Okay, brachial artery has opened up. In spite of that, you are not listening any Korotkoff sound. Okay, you are getting Korotkoff sound, but quite late. Okay, when brachial artery has significantly opened up, then only you can start listening Korotkoff sound. So initial few seconds, you do not listen Korotkoff sounds, even after opening of brachial artery, right? During deflation of the cuff. Right? So the cause is as there is a disease process called atherosclerosis, so blood vessels are sclerosed. Okay, blood vessels are sclerosed. Okay, and when the blood vessels are sclerosed, they do not allow transmission of turbulent sound. Okay, a sclerosed blood vessel does not allow transmission of Korotkoff sound through the arterial wall. Right? So you do not listen to the sound. Right? So this is called oscillatory gap. So how to overcome this oscillatory gap? You need to do palpatory method first. Okay, so in palpatory method, we don't depend on Korotkoff sound, we depend on palpation. So once brachial artery opens up during deflation, immediately you feel a pulse. Okay, immediately you feel the pulse and you catch the point. That is systolic blood pressure, right? So maybe it may happen that in palpatory method you got the pressure as 160 systolic blood pressure, and in oscillatory method you got it as 140. Okay, so your final take point is 160, right? So 140 to 160. This region is oscillatory gap. Clear?
Sir, definition টা লিখে দিন স্যার।
ডেফিনিশন কি তুমি এক্সপ্লেইন করতে হবে
লাইট আর মানে
কি করলি লেখা আছে তো বইয়ে পড়ো তারপর তুমি চ্যালেঞ্জ করতে হবে ঠিক আছে তারপরে আমি আছি কোনো পার্টিকুলার ডেফিনিশন দেওয়া একদম বুকিশ ল্যাঙ্গুয়েজে বলা ঠিক আছে বুঝেছো কিনা আগে বলো ঠিক আছে For all of you, the most important point is whether you have built up the concept or not. Once you have built up the concept, then you go for proper medical language. Okay, describe it in a proper medical language, define it. But your first target should be to build up concept. This will be repeated. Okay, because whole cardiovascular system is remaining, and I am in charge of that cardiovascular system. Right? So whole cardiovascular system I will be teaching you. So big concept, big concepts in front of you, right? So first make concepts, then try to express it in proper medical language. right? Okay. So only 2 minutes time remaining. Okay, so in Bernoulli's law, we talk about law of conservation of energy. Okay, law of conservation of energy, and this lateral pressure we take it as energy. Okay, in physics somewhere you might have read, or maybe in the BSc physics level, that we can convert pressure into energy. Somewhere you may have read, right? Okay, so this lateral pressure is considered as energy, right? So this lateral pressure actually, okay, let me draw it. So two energy heads. We are as gravity difference is not much there. As gravity difference is not much there between few segments of blood vessel. So we can neglect the potential energy. So we have the kinetic energy, right? We have the kinetic energy for blood, that is half rho v square. Half rho v square, the kinetic energy of blood, and the lateral pressure. That is also energy. We call it lateral energy, right? So half rho v square plus this lateral energy, this should be constant, right? This should be constant. So what happens if at a particular point the blood vessel is narrowed down? Constriction. Okay? If there is constriction, what will happen?
Pressure difference.
V variable. Right. Velocity variable. Right. Velocity variable. Right. Velocity তার মানে এই velocity টা v1 এটা হবে half rho v2 square. Okay, now v2 greater than v1. Right. V variable. Okay. Usually twice. Okay. So v2 is equal to v into v1. Okay. So half rho v2 square, now new kinetic energy. Okay. At the constriction, half rho v2 square and a new lateral energy. Okay. And this lateral energy will be low. Okay. The sum of lateral energy and kinetic energy will be constant. Right. Now, once this lateral energy is low, so it is further helping atherosclerosis to grow. Getting? So, if someone is suffering from atherosclerosis, it is a vicious cycle. The more atherosclerosis process will continue, and this atherosclerotic plaque, it will grow, and finally the patient has got the propensity to completely block that artery with that atherosclerosis plaque. Get my point?
Yes, sir.
So what happens in atherosclerosis? So initially we have endothelium, then we have smooth muscles, below collagen, right? So this is the structure of a blood vessel. Now there is endothelial injury. Okay, endothelial injury. Once the endothelial injury is there, LDL or low density lipoprotein deposits, and further cholesterol deposits. The patient's serum level of cholesterol and all these things are great. Okay, so cholesterol, all these things will deposit and it will form foam cells. Foam cells are the cells that contain LDL, cholesterol, all of these things, right? Now once foam cell deposition occurs over here, so both ways it may happen, or one way here. So blood vessels ultimately being narrowed. Okay, blood vessel ultimately being narrowed down. Now when the lateral energy is normal, it keeps the blood vessel patent. so that normal blood flow happens. Okay. Now once lateral energy is less, this lateral energy is less. Okay. So it helps this atherosclerotic plate, to further grow, because this lateral pressure works both ways. Okay. So this is how once the atherosclerosis process has started, it will further help to grow the plate. Okay. And finally, the artery may block. Okay. And mostly it happens in coronary arteries, you know. Okay. In angiography, we see the 60% block, 30% block, 50% block. Cardiologist will be telling you there is a block in the right coronary artery, there is a block in the left circumflex artery. This much percentage is blocked. We need to go for a bypass surgery. Okay. Got it?
Yes, sir.
Okay. So this is Barnum's principle. You know Barnum's principle from your physics knowledge, and this is the application of Barnum's principle in case of atherosclerosis. Right. So all of these questions might be asked from if you get blood pressure measurement in your practical, right? So questions are many. What is blood pressure? What is systolic blood pressure? What is diastolic blood pressure? What are the factors that depend on the Korotkoff sound? What are the phases of Korotkoff sound? Right? What are the phases of Korotkoff sound? Next, what more question we discuss? What are the factors that causes hypertension? Right? What are the gradation of hypertension? Grade 1, grade 2, grade 3, right? So all of these are questions. What is the diameter of the river of the calf? Okay, dimension of the river of the calf. Okay, name of the calf is river of the calf. Sir, what? Sir, what the calf? River of the calf. River of the. Name of the blood pressure calf is river of the calf. Right? The dimension of the calf. So many questions from blood pressure. Okay, so many questions from blood pressure, and once your cardiovascular system, and yes, definitely the concept of mean arterial blood pressure, very much important. Why it is examiner will ask you why it is LDP plus 1/50? Why not SDP plus DDP by 2? Right? So all of these things are important. So physiology is only concept. Okay, nothing to remember, absolutely nothing to remember. There are few chapters like endocrinology where something you need to remember, but mostly physiology is concept. So the more you build concept, the more it will be easier to practice anything, right? Okay. Thank you.
As well as second year, because final exam of foundation will be on the 4th year. After completion of 7th semester, right? Because we already introduced about the course curriculum. You know the class, right? So what I suggest, you just attend the class of community medicine and read those things only, right? Well, in class only power. First semester, no, only one semester will be there in the first year, and we'll try to make it on MCQ oriented. Will be convenient for you?
Yes, sir.
Huh?
Yes, sir.
No, that will be, towards the exam oriented. We have to maintain the criteria. That criteria will be there on 3rd semester and 4th semester onwards. Generally, in the first year, we make it of MCQ oriented. That will be very beneficial for you. Because you have the giant subjects in the first year, biochemistry, physiology, and NDS1. NDS1 will play with the head map, right? Right, so anatomy. Suraj, this section?
No, sir. Class থেকে কোনো দিতে পারে।
So here, over anatomy. Okay. This is the slide, so. Okay, it will be there now. Color changes. So again, most probably I am going to introduce the previous classes. on the last Wednesday I took a class on most probably principles of time practice. Many of you attended, many of you don't attended, right? Raise your hand and who attended the class of mine. Okay. So that was the class. Thank you. Okay. That was the class on principles of time practice. We expect that at the end of the course, you learn everything from cognitive medicine, everything from other disciplines, and apply those science in community level. Hospital level to asay, that will be taken care by different disciplines like medicine, general surgery, pediatrics, gynae, right? Orthopedics. So many disciplines there. But we expect as a community medicine specialist, someone say preventive medicine specialist, many of us say family medicine specialist, many of us say public health specialist. So we don't know actually what kind of specialist we are, but we expect that at the end of the curriculum, you will apply your learned skills in the community level. On the bulletin, that two center will be there, primary care level center. One thing is urban health training center, that will be very close to Santini Medical College, Bolpur municipal area, there will be the VSPC. And we choose a rural area. You will go there, you will be posted there, you will learn all things about the rural area. Right? Second, so that was the principle of family practice. Now we will talk about the introduction to coordination. Because it's a very vast subject. It's one of the major subjects in medical science. First step they correct act of intensive volume. So it's a major subject, right? Basic subject first year second year, coordination is high. And again, whenever you are preparing the MCQs for your PG entrance, most number of questions will come from cognitive medicine, right? So be attending in each and every class. Read annual qualification in this year, no problem, no issue. From the next year, follow each and every class as well as spend some extra time on your textbook of medicine. Most probably I have communicated via Dr. Goswami a standard textbook for cognitive medicine, that is preventive parts textbook of preventive medicine. So usually practice textbook across the country. And apart from that, we also suggest Anita's textbook of health planning and health program, right? A statistics book must be there to learn the biostatistics. We generally recommend principles of biostatistics authored by Professor Indramin Saha and Dr. Boypal. Those things will be learned in the later classes, right? So myself, again, Dr. Susmita Chakraborty, I am your assistant professor in the Department of Cognitive Medicine. I expect that at the end of the class, you will be able to know what is community, because we are cognitive medicine specialists. What do you mean by cognitive medicine? Very closely related term, family medicine. Most probably this class has been taken role of IMG. Again, a very close term related to our subject discipline, that is preventive medicine and public health. Right? So first of all, community. Community meaning soil. I belong to a rural community. Right? I belong to a tribal community. I belong to Indian community. So this is the examples. So basically, community means it's a group of people or group of family or group of some people who are living together within a larger society and share common characteristics or interests. Right? Like Ukrainian community. A war is going on, Russian community. A community usually have their own customs, traditions, leaders, or even language. Like example of a community, village can be a community. Your tribe can be a community. Islam can be a community. Different religious groups can be a community, right? Hindu community, Muslim community, big hospital group of community, small group of hospital like community, etc. So cognitive medicine, it's a branch of medicine, modern medicine, that deals with the health and disease in the population of a defined community or population. Its goal is to identify health problems and needs of the defined population and to plan, implement and evaluate the extent to which health measure effectively meet these needs. Like for your example, better understanding, like you are working in rural area of Birbhum, somewhere in a place as block medical officer at BMOH, right? And there you came to know that there is a problem of iron deficiency anemia or nutritional anemia in your field practice area, right? As a community medicine specialist, you need to evaluate all those things. You have to think about resources, what resources we have, and you have to manage the problem with locally available resources. All those things you need to know, right? What Royal College of Physicians is a renowned, educational organization you all know. Actually, I also have a diploma from the Royal College of Physicians UK. What they say about community medicine, that it is a specialty that deals with populations and comprises those doctors who try to measure the needs of the population, both sick and well. Again, it's a branch that deals not only with the sick person but also with the healthy person. I mean, I explained my way that why this need is necessary for all of us. I am looking apparently healthy, but if I screen for diabetes may come up. If not, I have some sort of weight gain. So many risk factors of different diseases, so I have to reduce the risk. If I don't have risk, I need to promote myself, right? Promote our health. So in cognitive medicine, whatever you will be learning in the traditional medicine like general medicine, surgery, there will be a word. Acha to general surgery word, general medicine word. এখানে হচ্ছে in your body also. দেখেছো তো? ওই এক্সাম্পলের মধ্যে ডিফারেন্ট ওয়ার্ড দেখানো হয়েছে। দেখানো হয়নি, তাহলে দেখি দাও no problem. So in traditional medicine practice, what you see, there is a word, dedicated word. For your example, we understand general medicine word. Some beds is there and some patient is there to occupy those beds. But in cognitive medicine, we consider entire community as a word, and family as bed, and individuals as beneficiaries. Like that. Very closely related discipline. Family medicine is a newer discipline coming in our country also. It's a branch of medicine that deals with health and disease in a family and provide a comprehensive, preventive, promotive, curative, rehabilitative and palliative care. आगे दिन में example लेके चलो, right? Comprehensive health is very important. Holistic health is very important. It's a cancer also. Some patient is suffering from terminal stage cancer, last stage. He is suffering from lots of pain. Even your chemotherapy directly can't do any help. Palliative care. Good. Your patient comes to you with some signs symptoms of malaria. Diagnose them, treat them. Curative care. Your area has a problem of measles. Vaccinate the eligible babies. Prevent. Right? And rehabilitate, many of you have been rehabilitated. Mother infraction error আছে. Treatment নেই, you have been rehabilitated. Right? Simple example for your better understanding. So this discipline, usually works in the primary care setting, in continuum home to room, janmo theke ekdom mrityu obdi, right? These subjects share similar domains with cognitive medicine. This specialty is usually practiced in the developed countries like US, UK, and nowadays this family medicine course separately has been introduced in the DNP system, Diploma National Board, as well as different MD also coming out in the upcoming days. মানে তারা হচ্ছে better family physician. Basically, they are better family physician. They has been trained in the field of general medicine, obstetrics, gynae, and they can manage each and everyone, at least primary and some sort of secondary care. Right? Family medicine and family medicine is different from other specialties. Because these two subjects deals with common elements in the community or in the family to provide a comprehensive primary health care. Comprehensive মানে বলতে পারলাম, তুমি একটা एग्जांपल আজকে বলেছি, আগে দিনও বলেছি, those dealing with the individuals, মানে only patient, they only treat that patient, right? আজকে আমার টাইফয়েড আছে, today I am suffering from infection. I will visit a physician. He will provide some professional diagnosis. Based on professional diagnosis, he will advise me to go for some examination, pathological examination. Whenever he gets confirmation, he will start any medicine. My disease will be cured. But whenever, as a family physician or community physician, you are seeing the patient in the family, you will see or you look for the source of recurrent entry fever in the family. You look for hygiene. You look for whether their cooked food is stored in a proper place or not. They are garbage disposal in the proper way or not. They have a sanitary latrine or not. Right? And if possible, vaccinate the eligibles. Vaccine to acha. Kichu disease. Right? Target population for both disciplines. Usually the healthy one as well as the diseased one. Right? Both are target population. Place of work usually in the community setup. যেখানে বড় হাসপাতাল নেই সেরকম সেটাকে they work. Cover a large scale of population. Responsibility of care in community medicine. Responsibilities of prevention and cure of common endemic diseases are not confined only to doctors. It's shared with the community, with their participants. Like whenever you are working in a rural or urban community as a community medicine specialist, right, or doctor, your knowledge sharing will be with your patient as well as with the stakeholders of the entire community. An example is malaria. Naam sunecho? In certain places, insecticide-treated mosquito net is provided free of cost from government sector. Panchayat ho jaya. But to avail that, if criteria is there, কোন এরিয়ায় কতটা ক্যালসিয়াম পাওয়া যায়, অ্যানুয়াল ক্যালসিয়াম ইনডেক্স বলে একটা কথা আছে, we learn in the 6th semester most probably, right? একটা ক্রাইটেরিয়া আছে, more than 5 হলে ফ্রিতে পাওয়া যায়। একটা এক্সাম্পল দিচ্ছি, ক্রাইটেরিয়া মেনে চেঞ্জ, তাহলে তুমি কি করলে, যেগুলো ডিজিজ ছিল সাথে ট্রিটমেন্ট করে দিলে, আর যার নরমাল আছে হেলদি ট্রিটমেন্ট করলে, প্রোভাইডিং দ্যাট ইনসেক্টিসাইড treated mosquito, so that the other people don't catch up. As well as you suggested the municipality or panchayat pradhan to take steps against mosquito, right? Bolle that is the potential source of breeding place of mosquito. Eliminate. If that those concerned authority has enough fund, they will do that. Disease of interest and type of care. These subjects usually deal with common health problems in the community or problems with public health interest. Usually, those diseases have greater impact in our society and has more burden, economical burden in our country, in the community. Example, the health disorder. The problems in our country. Nutritional anemia, still a problem problem in our country. Right? Maternal mortality is a problem in our country, though it has been drastically reduced. Right? So this kind of physician usually takes care on those diseases. Those have public health interest. Right? Indian medical graduates in family care practice, most probably, এটিকে পড়ানো হয়েছে? হ্যাঁ স্যার, এটা হয়ে গেছে। Time lag. You know the responsibility, what we expect Indian medical graduates in the family care practice, right? One of the opportunity. So last line is very important. From this discussion, we already been taught mostly 3 class now. 3 class was there, right? In the orientation program. The role of Indian graduate. So stated role. Enter things by NMC. The enter discussion makes a clear understanding that Indian medical graduate must do family practice and it will be part and parcel of the practicing medicine as Indian medical graduate. যেটা প্রিন্সিপাল আমি আগে তোমাদের সঙ্গে ডিসকাস করছিলাম, 10 golden principles of practice ছিল তো তোমরা ক্লাসটা। Many of you have attended, as far as I can recall. So again, very closely will be termed preventive medicine. There will be communication like preventive medicine specialist. But preventive medicine specialist means it's a different term. Refers to measures taken to prevent disease rather than curing them within all areas of medical medicine. Like if I see a pre-diabetes patient, diabetes the patient has no over-diabetes. I modified his diet and lifestyle is a preventive medicine. I started a metformin, a medicine, a drug that helps to combat diabetes. It is also a preventive medicine. Immunization, vaccination, preventive medicine. Health education, health promotion, preventive medicine. Right? So specialists in the preventive medicine are uniquely trained in both clinical medicine and public health. They have the skills need to understand and reduce the risk of disease, disability, death in individuals in the population. Community medicine people also trained in such a way that they can work as a preventive medicine specialist. Right? Public health. Again, many of you will learn that community people means they are public health specialists. True in some sense, right? Any activity that safeguards public health interest is public health. In short, any activity that safeguards any activity related to related to safeguarding the public health, and public health that can be termed as public health in medical aspect. Organized measure definition আছে প্রত্যেকটা organized measure to prevent disease, promote health and prolong life among the population as whole through organized community effort for the sanitation of environment, the control of communicable infections, the education of the individual in personal hygiene, the organization of medical and nursing service for early diagnosis and treatment of disease. এত কিছু নিয়ে হচ্ছে পাবলিক হেলথ। Sanitary activity করতে পারি we are able to educate people about the sanitation and hygiene. So many diseases will be eliminated or will be reduced in number, huge number. Recent example, COVID. Sanitary, though that is a relationship. Hand wash, hand hygiene. Recent example, right? Many of you have been already in your childhood immunized with BCG, a vaccine that prevents severe form of childhood tuberculosis. BCG দিলে টিবি আটকায় না। এগুলো আছে BCG ভ্যাকসিন নিয়েছি মানে আমার টিবি করতে পারবে। It prevents severe form of childhood tuberculosis. তাতে মৃত্যুর চান্স অনেক বেশি। Mortality chances much higher. And initially, during your childhood, immunity system is underdeveloped. It's a developing stage, right? যে কারণে BCG ভ্যাকসিন দেওয়া হয়। During birth, they go miss করে. If someone miss, then progression of taking BCG vaccine within first year, within 1 year of life. Usually, সুবিধার জন্য আমাদের দিদিমণিরা provide BCG vaccine at 1.5 months. 6 weeks. এখন তো একবার দিতে হবে, রাইট? আর অনেক ভ্যাকসিনেশন হলো লাইক polio. Polio was a troublesome in our country few decades earlier. দেখেছো তো অনেকে দেবে প্যারালাইসিস আছে পায়ে, দু একটা দেখতে পাবে, নতুন হয়তো দেখতে হবে না, নতুন হলে তো খবর হয়ে যাবে, it will come in the front page. দেখতে পাও কি নতুন প্রেস শুনতে পাবে। স্মল পক্স শুনতে পাবে। যদি আজকে একটা হোয়াটসঅ্যাপে দেখলাম যে একজন মেডিকেল অফিসার সার্টিফিকেট করেছে দ্যাট দিস পেশেন্ট ওয়াজ সাফারিং ফ্রম স্মল পক্স and rest was advised for 15 days. তাই না? সত্যি না হতে পারে। And unfortunately he is the MBBS, like he or she whatever, I don't know his name, he is a heart. He already been taught that this disease has been eradicated. যে ডিসটা নেই রেজিস্ট্রেশন নাম্বার দিয়ে লিখেছে, মানে সাম ট্রেন কোয়ালিফাইড মেডিকেল পারসন। এমবিবিএস মতো আমাদের মডার্ন মেডিসিন সবচেয়ে ইম্পর্টেন্ট স্টেপ, মোস্ট ইম্পর্টেন্ট ডিগ্রি ইন মডার্ন মেডিসিন ইজ এমবিবিএস। তার উপর তো চলতে পারে না, এমডিডিএম যাই করে এমবিবিএস ছেড়ে দেওয়া হবে না, it can't be. So even with the proper training and education, he or she given in medical whatever may be wrong, WhatsApp অনেক কিছু করে বলে। সে আমাদের ডিজিজ সম্বন্ধে লিখলো মেডিকেল হসপিটালে যে ডিজিজটা এক্সিস্টই করে না, the disease does not exist in our country. তাহলে কেন বলেছিল? with proper planning, implementation and preventive measures, with good political commitment. আমাদের পলিটিক্যাল কমিটমেন্টও লাগে, শুধু আমাদের কমিটমেন্ট হবে না। আজকে দিও কমিট করে দেয় আমি সবাইকে সুস্থ করব, if he commits something হবে না। He needs a backup, a good political commitment behind his upcoming success, right? এগুলো ছিল বলে হয়েছে, পোলিও আমাদের দেশ থেকে চলে গেছে, এগুলো আছে বলে so many factors there. তোমরা আরো ভ্যাকসিন নিয়েছো, কি ভ্যাকসিন নিয়েছো বলো, দু একটা নিজেরা জানো তো? catch diseases. এবার যে ডিজিজগুলোর কোনো প্রিভেন্টিভ মেজার নেই, মানে ভ্যাকসিন নেই, সেগুলো দিতে পারবেন। প্রিভেন্টিভ মেজার্স দেয়া, you can catch up hepatitis C also, HIV/AIDS also as an occupational exposure hazard. If preventive measures, whenever you are seeing those patients, put even personal protective equipments, vaccination here. You have personal protective EPP, তোমরা নাম রাখা জানো সব, thanks to corona, right? আগে তো হয়তো জানতেন না। So PPE was there before corona also. So it's a kind of prevention, right? So public health works for beneficial safeguard our interest, public's interest, population interest. They work for sanitation. They work to control the communicable disease, malaria, dengue, kalajor, diarrhea. Those are communicable disease. একজন কালে কালপিট একটা মশা ধরলাম, for your understanding, যে 20% তার রক্ত নিল, 15 জনকে কামড়লো, তার রক্ত তার শরীরে চলে গেল, এইভাবে তো ছড়ায়। এখন যদি আমি 20% কে I contain in certain place and treat him, and other vulnerable people if I provide the protective equipment, and if I go for mosquito elimination program, Komida program dilo hoy, larger section will be safeguard, they are getting safeguard, right? That is the public health. The public health is a combination of scientific discipline like epidemiology, biostatistics, laboratory science, social science, demography. Everything is very important. And skills and strategies like investigation, epidemiologic investigation, planning, management, intervention, evaluation, that are directed to the maintenance and improvement of the health of people. It is based on 3 core principles, that is assessment of a problem, policy development, and assurance. Different specialties of public health, more or less software cover hobe under community medicine from first year to 4th year, first part 1. Epidemiology, biostatistics, demography, communicable disease epidemiology. Example, corona, covid, একটা example দিলাম। Non communicable disease মানে those diseases does not communicate from one. Obesity, cancer, right? আরো আছে diabetes, এরকম এক্সট্রা পড়ানো হবে। Health education and health promotion, mental health, school health, community nutrition, environmental health, occupational health, adolescent health, reproductive health, maternal and child health, health program and policies, health system and services, international health, travel health, health of people with special needs, genetic health. An entire MBBS curriculum is being covered in this subject. In first year subject basic medical science subject right, more or less. That's why it's one of the major subject. Software subject পড়ে নাও তাহলে এটা অনেক ইজি হয়ে যাবে, but unfortunately many of important subject you learn after passing community. That's why it will be very beneficial for you to work in the community level. Whenever you will be posted in the department of community, you will get internship, right? That's all. তোমাদের মাথায় everything has been stored with major hours of anatomy biology. extra store করা দরকার নেই। আমি এন্টারেজ করি না আজকে পড়ার জন্য, এটা জাস্ট নোট ডাউন করে নাও, যদি কোনোদিন এমসিকিউ এখানে দেবো না এমসিকিউ। Next class will be on evolution of this community medicine, public health, man and medicine.
Can I chosen side? You don't know.